Good afternoon, everyone. So welcome to this, the second formal meeting in public of the South East London CCG governing body. Particularly welcome to those of you who are joining us online via this live streaming. Obviously, we continue to be in an emergency response as part of the pandemic and therefore unable to meet in person, but I very much hope the way in which we've managed to establish these meetings are enabling people to feel fully engaged with the work that we are doing as a CCG. My name's John T. Hevetage. I'm a GP in South East London and I'm the chair of the governing body. I guess just first and foremost, it's worth flagging that whilst we are in still an emergency response to the pandemic, I hope what you will have noticed over the last few weeks is that we have been able to begin to establish a bit more of a rhythm as a new CCG across South East London. So our borough boards have now all met in public as well, and there have been fantastic interactions going on and work within local boroughs that we will pick up on later in the agenda. But equally, we have started to do a lot of work as a CCG to understand the impact of the pandemic and to think about how we work with providers of care across South East London to ensure that we are mitigating some of that and in particular addressing some of the inequalities that could result from the impact of COVID. So we will pick up on that during the agenda, and you'll start to see that compared to the first meeting, the agenda is a combination both of information about the pandemic response itself, our planning for the next phase of the pandemic, but also some of the business that we had begun and need to continue as a CCG now that we're entering the next phase of our response. I hope that's helpful just by way of introduction. What I wanted to do was just pause for a second, because we are inevitably going to be working with technology. That requires us to have some slightly different processes in place to essentially manage and orchestrate the meeting. And I was going to ask Christina just to say a word or two so that those people who are watching the meeting as well as those participating in it understand how this will work. So Christina, can I just hand to you for a minute?
Yeah, great. Thanks so much, John T. Yeah, so I'm Christina Windle. I'm the Chief Operating Officer of the CCG. Just want to echo my welcome and thanks to anyone who might be watching us on live streaming. You'll see that there's a Q&A function and that Q&A function is open at the moment. And as per the agenda, we've got a session both at the beginning and at the end to deal with questions. So please post your questions. We'll come to them in that first Q&A session. We had some feedback from the last governing body that we ran that it was a bit confusing as to when questions would get answered. So what we're going to do is after that first session, we will actually close the Q&A up until later in the agenda, so about 20 minutes before the second Q&A, which is about when the Lambeth Hospital item starts. We'll reopen the Q&A and you can post your questions. We will monitor that, and then when we come to the second Q&A, we'll pick up as many of those questions as we can. Just to echo the commitment that any questions we aren't able to answer in this session, we will absolutely come back to and publish afterwards. And in fact, a thanks to those of you who have asked questions already. We received 7 questions ahead of the meeting and we have published responses which are available on the website. And if you asked a question, we will have come back to you with that link as well. And we'll post the link in the chat so you can see those answers. So as I say, questions are open now. Please ask the questions. We will then close for a period of the meeting, but we will open again about 20 minutes before the questions and then address as many questions as we can in the meeting with the rest followed up afterwards. Thanks. Back to you, John T.
Thanks, Christina. That's great. So we will come to the to public questions in just a moment. Before we do that, I just wanted to introduce the governing body to you. We are not, there are more than 30 people gathered today, so I'm not going to get people to introduce themselves individually, but I know members of the public previously wanted to be able to see who is gathered online today as part of our governing body. So we felt the easiest way to do this was to show you our pictures. These are pre-COVID pictures, I should say. So appearances might have changed somewhat, particularly hairstyles, I suspect. But this gives you a sense of the people who are joining today. I think what I've also asked is that anybody on the governing body who is presenting or asking a question, just introduce themselves and their role at the beginning as well, so that we can ensure that everybody knows who is speaking. And I think I just need to then also check, because I'm assuming not everybody is here, what apologies we have, Christina. What apologies do we have for the meeting today?
We just have one from Sam Hepplewhite.
Great, thank you very much. And then in terms of the business of the meeting, just before we get into public questions, can I just ask us all to review the declaration of interests that have been circulated with the minutes, and identify whether there are any changes to your declared interests that we have registered as a CCG. So I think if you could just let me know if you have any changes in your interests. Nope. Okay, then I'm going to assume that that is up to date. Obviously, if there are any changes, then we have a process to ensure that those are captured. And I'm noticing also that Sam Hepplewhite has sent apologies, as has Kate Moriarty Baker. So we'll ensure that we record that accurately in the minutes. Can I just go to the minutes of the last meeting of the 21st of May and ask whether any members of the governing body have any concerns over the accuracy of the minutes? I'm not going to take them a page at a time. I'm just going to ask whether anybody would like to raise any concerns over accuracy.
None for me.
Okay. Sorry, was that somebody coming in?
Sorry, I was just saying none for me.
None for me, great. Okay. So there is, I think, Neil, did you just want to come in?
No, I didn't need to come in. I was just clarifying my job title needs to be updated to reflect the change.
Great, thank you. That's very helpful. Brilliant. All right, so we'll accept those as an accurate record of the minutes, and I noticed that there are no outstanding actions. And as far as I'm aware, Christina, no matters arising. Is that correct?
That's right.
Great. Okay, in that case, we will move on to public questions. I guess it is worth, I just wanted to reiterate what Christina said at the beginning, which it's been incredibly helpful to have questions in advance from a number of members of the public. Those who did ask questions will have received an email today with a link to the answers, which have been published on our website and will also be published as part of the minutes of this meeting. There were a wide range of questions asked, which I think shows really positive engagement. And a lot of them were around, for example, how we are managing the backlog of patients and the waiting lists that have developed, whilst our acute trusts, of course, have been working incredibly hard to manage the demand associated with COVID. There were questions about the role of the CCG working with local authorities to manage any future spikes in numbers. Questions around actually the consequences of the virus, the longer term consequences of the virus on individuals, around the testing processes, how surveillance is working with the tracking system to reduce transmission, how we are working with acute providers to restart elective work safely, and some questions also on the financial impact of the pandemic on the CCG and our allocation. Some of that will be picked up in the agenda, but all of those questions have been answered and published, so please do take a look at those. But of course, we also want to open up now for any further questions that you have. So on that basis, Christina, I think you are going to manage the questions. Did
Yes.
you want to help us through that?
Yes, please. Thank you very much. And thank you, because people have been asking questions, which is fantastic. So the first question, and I have published it, so hopefully everyone both in the meeting and outside of the meeting can see. And I wonder, Jonty, whether you might help us answer this one. So the question is, it's been reported that all GPs will no longer take telephone prescription requests from September, which will adversely affect older people over 75 who may not have IT. The NHS has performed heroically, keeping the majority of older people alive, but could this process potentially be reviewed? That's the first question.
Thanks, Christina. So I think what it's important to recognise is that for some time, in relation to, I guess, both clinical safety and just to manage the work pressure on practice staff, most practices have not accepted telephone requests for repeat prescriptions. That's certainly been the case for as long as I've been a GP. But in the past, these would tend to come to the practice physically or be arranged through the local pharmacist by using the repeat prescription slip that's attached to the prescription. Obviously, with the advent of online access and electronic prescribing, it's now possible for people to order prescriptions electronically, and these can be sent then by the GP directly to the community pharmacy. This has obviously proved very convenient for people, but also been really helpful during the pandemic because it's allowed us to reduce the number of people who are coming into the practice and into practices, putting them at risk of transmission. But I think it's just really important to reiterate that despite that now being an opportunity for people to use, that does not mean that people cannot contact the practice still by telephone. So during the pandemic, people have been using telephone as well as online access. There are no proposals to sort of, if you like, enforce every patient having to use online prescription services. But what we would do is to continue to encourage people to use that approach, or to speak to their local pharmacist in order to order repeat prescriptions, and still, of course, to telephone practices, because we know that for many people, access will be difficult. So the issue here is that this is an additional way of being able to order prescriptions. It is not going to become the only way to order prescriptions, because we absolutely recognise there are people in our population who would find it very difficult to use technology in that way. I hope that's helpful in response to that question.
That's great. Thanks so much, Jonty. The next question, again, this is published, but I'm going to split it into a few because there's a few parts to this. So it's from the Lambeth PPG network. And the first one is commending the PHE report and the recommendations, the 7 recommendations that are made. There's a question about whether the CCG is committing to delivering these and whether the Equalities Committee will be leading on the actions necessary and linking to the public. I was going to make a comment on this, and then I'm not sure if either Farouk or Joy might want to add to it. Just to say, absolutely, we are looking at those recommendations. They were discussed in the first meeting of the Equalities Committee, and we are working up action plans that aim to cover and go beyond what's in there. I think what's important to say, though, is they're not all things that the CCG itself can deliver, and this is this and the equalities agenda more broadly is absolutely critical that we do with our partners across the ICS and a local care partnership level. So we will be engaging with them on the best kind of joint approach. I don't know if
thanks. Yeah, Christina, I'm just going to bring, so worth also, we will, I hope if technology works, we will hear from Kevin Fenton later in the meeting, and of course we have an update from public health colleagues as well. But I wonder whether Joy or Farouk, you would like to just comment on the work that you've been doing as part of the Equalities Committee.
Yeah, sure. Shall I start?
Yeah,
thanks very much, and thank you for the question. I'm Joy Ellery. I'm a lay member and I lead on patient and public involvement. Yes, we've had our first meeting of the engagement committee, and that was preceded by a lot of discussion around engagement, diversity and inclusion, just mobilising what we do. The engagement committee has met for the first time, and it is in development. We have set out our ways of working, and we are still looking to improve that. Certainly the Public Health England requirements or recommendations have been in the middle of our thinking about that, and Christina has alluded to that. I'd just like to talk a little bit about engagement as well, because the question asked about digital or non-digital engagement, and we have also been running task and finish groups, how to engage with people that either want to engage digitally, and a second group on those that are not able to engage digitally. So we are gathering experience about that as well. But absolutely, the role of the Equalities Committee will be fundamental to the work, and we are gathering experience on how to improve our engagement on the recommendations that we're discussing.
Thanks, Joy. Farouk, obviously you're clinical lead in this area. Is there anything further that you wanted to add about the work that you've been doing?
Only to say that, I'm Farouk Majid, I'm a GP from Lewisham and clinical policies lead. Only to say that we've looked at all the public health recommendations, but also in the Equalities Committee, taken account of the various other concerns and recommendations that people have had from around the country, including documents from Wales, from the British Indian Doctors Association and various, as well as the comments and suggestions from clinicians locally and from people in the public within GP surgeries who've commented on areas. And we've tried to put together some recommendations for the CCG as well as the wider ICS for consideration, which includes all the public health recommendations, but goes beyond that.
Thanks, Farouk, that's really helpful. Sarah, did you, Christina, did you want to just, I think there are some more questions.
Yeah, so the second part of the question is about the recovery plan. So I note the recovery plans are being submitted to South East London CCG tomorrow and will then be the subject of engagement. It's just a question asking whether the plans will be co-produced with people, communities and the voluntary sector.
So shall I come in and answer that one?
Thanks, Sarah.
Jonty. So hello everyone, I'm Sarah Cottinger, Director of Planning and Commissioning for the CCG. So absolutely, firstly, just to stress, the plans being submitted tomorrow are first draft plans, and much like the development of those plans, the aim and objective is absolutely engagement that takes place at local level, is borough-led and seeks to co-produce in the way suggested by the question. So the intention is really the opposite of an engagement approach that's mandated from above. The only mandate is that we engage, and doing so will be through processes developed locally, with the objective of then ensuring involvement of the public, communities and the voluntary sector. So I think we can absolutely say yes, that is the objective in line with the question asked.
Thanks, Sarah. Christina, that picks up those elements of the question. Is there anything else that we needed
Thanks,
to?
Yeah, the last bit of the question was just which is just about where there isn't an opportunity to answer questions in this type of session, is there an opportunity for follow-up? So I think with that, of course, you know, this is a meeting in public, and we aren't in this forum kind of able to have a full-on dialogue. But if there are follow-up questions, then we, if people are sharing them back with the email address, we will aim to make sure that they are picked up in some form or another. And then the next question, if that's okay, was from Tim Bradley from Wellbeing Map. again, this is published so people can see. As health appointments go increasingly online, the CCG must still reach users that don't necessarily have digital access. And so I think the question is just about what initiatives and engagement is there for ensuring that there is this inclusion.
So Tim, thank you. I guess one of the things that has concerned clinical leads and the governing body has been obviously the significant benefits in terms of using digital technology, and the deployment of technology has sort of grown exponentially during the pandemic. But the concern very much has been around the extent to which that may create inequalities or discrepancies within the system in terms of how people can access care. I guess the first thing to say is that that has not reduced any of the other ways in which people can access care, and that's very, very important, so that people should still be able to, as I mentioned previously in relation to prescriptions, for example, be able to access the support that they need in other ways. I think the issue of digital inclusion is incredibly important, and my hope is that a lot of the work on this will take place at borough level. So the work that I think you flagged in your very helpful post with the voluntary community sector to ensure that particularly those parts of our community who perhaps struggle to use digital technologies effectively will be engaged and involved is incredibly important. Some of the work that I know I've seen from Health Watch in Greenwich to understand the impact of the pandemic on particular parts of our community. And it's not always the people who we assume who can't necessarily use technology in that way is going to be really important. So there's a significant piece of work underway at the moment to inform borough plans, to understand more about the impact of the pandemic, in particular using our public health intelligence to understand our population and where there may be additional inequalities associated with our response to the pandemic. That will then inform those local plans. And I would absolutely expect to see, as they emerge, clarity on how they're going to ensure equality of access around some of these digital technologies as well. Martin, were you going to come in and say a little bit about the working?
Sorry, John, just for the next question, if that's okay.
Okay, that's fine. Yes, thank you very much.
So I think we've probably just got time for one more question in this session. There are a couple of other questions, but we'll absolutely make sure we come back to them in the next session. So thank you for that. So the last question is from Mary Mason, and that's, please could you comment on what impact of COVID-19 there's been on mental health needs in Southeast London, and what central funding has been made available to meet these needs, including crisis services?
Thank you. Thanks for that question, Mary. So my name is Martin Wilkinson. I'm Director of Integrated Care and Commissioning with the CCG, but also I lead on mental health commissioning across South East London, working with many colleagues. So thank you for the question. I think there's no doubt that the impact on mental health, emotional well-being has been huge in terms of the lockdown and COVID. And we are putting in place a number of initiatives working with our current providers and voluntary community sector, thinking about how we support how we support people in this time. And actually we're going to talk a little bit about our Free Your Mind campaign shortly, which gives us some more information and supports people to provide information and advice. I think it's also an impact for those with existing mental health conditions in terms of, again, the movement to online, not being able to access care works in the same way that people have had before. So we've been working with our mental health trusts and across this London system, thinking about our models of care and how we adapt them, including crisis services. We are looking at the funding as well. We're using existing funding streams linked to the long-term plan to make sure we build our community offer, as well as the support around crisis as well. Clearly, we're reopening some services. So, for example, the crisis cafes in some of our areas have not been taking clients, if you like, and supporting people in the same way, but gradually we are reopening those as well. And we've also been offering support through phone lines and crisis lines, but clearly has had an impact, and we are very mindful of that, and I think we'll come through in terms of our recovery planning and thinking over the next period. Thank you.
Nancy, did you want to add a word or two, or has Martin covered it pretty much?
I think Martin's covered it. I was just listening intensely to make sure that anything extra I wanted to say I wrote down, but actually I think you covered it all. Thanks. Great,
thanks, Nancy. Can I just check with Christina? Christina, any more questions?
So I think we should close it off there. There's a couple of things I think we can answer during the meeting, but if not, we will absolutely come back to them in the next question session.
Fantastic, thank you. It is worth just again reiterating there were quite a wide range of questions received before the meeting, so please do go and take a look at some of the responses to those questions, because I think it covers quite a broad range of the challenges that we're facing at the moment. And in fact, that last question in many ways sort of leads us helpfully into the next section of the agenda. For people may remember from the first meeting that we had, we try to highlight some of the good work and showcase some of the work that is continuing to happen in South East London, and we've got a couple of sort of showcases today. The first around the Free Your Mind campaign, and then we will look at the Tessa Jowell Health Centre. But I wondered if I could hand over to Nancy and then perhaps Martin to talk a little bit about the Free Your Mind campaign.
Thanks, Jonty. I realised I didn't introduce myself at the last bit as well. So I'm Nancy Cusham. I'm a GP in Southwark, and I'm one of the Southwark reps on the governing body, and I lead for mental health, learning disability and autism. So I'm really pleased that this is on our agenda today, and there's a chance to talk about it. We're all really aware at how the pandemic has affected our mental health. There was a lot of anxiety at the beginning of the pandemic, then there's a lot of change. Lockdown had a big impact on our behaviour, and there's been lots of loss and bereavement to deal with. So it's been really important that the South East London CCG and partners have taken this role in promoting mental health awareness and signposting people. Simon, can you move on to the next slide? So this campaign called Free Your Mind was launched in June. The CCG engaged a PR firm with a behavioural science approach to try and optimise the reach and the use of digital resources. The partners included local authorities and mental health providers, so that we've been coordinating some of the information that's available to people. The way it has worked, I think the next slide starts to describe that. So adverts were positioned on different digital platforms, mostly social media. You can see reference there to Instagram, TikTok, Facebook, Twitter. I know all my social media icons. And I think the clever bit about this was that depending on what people clicked on and how often and what sort of how many other websites people followed, the adverts were then reused. The popular ones were reused and spread out, so that there was optimizing the reach. Do you want to just move on to the next one? If once you'd clicked on the first advert, it would take you to a different platform, which would allow you to choose what kind of mental health information you'd like to find out more about. So there were options to click depending on your age and also the kinds of problems you're experiencing or information you wanted. And then the next click took you to a website with a lot more information, including signposting. Thanks, you can move on to the next slide. So the team put in huge effort, and there were a lot of tight deadlines. But what I think is really gratifying is the success of this campaign. So the information here you can read. It reached over to 170,000 people. A lot of people clicked on the extra links and reached the extra parts of the website. They even clicked on some of the further links to other digital platforms such as Kooth and Good Thinking. and the engagement has been much higher for than average health campaigns. There has been recognition of this work. So the final slide, I think, talks about a article commending the campaign, which is really positive. And it continues. So it's continuing in its current form until mid-August, and it's continuously reviewed and iterated to try and optimise response. I think it's going to really help us in terms of understanding who clicks, who's seeking which kind of information. We can feed some of that into our understanding of the new patterns of need. And I just want to say once again what an impressive campaign it's been and how pleased we've been with the response. I'm going to hand over to Martin just to add anything or clarify.
Thank you, Nancy. Yes, I don't think there's anything to add. As you say, it runs till the 22nd of August. Something about next steps. Clearly, we will look at what's come out in terms of any learning. It will inform sort of our needs assessment, if you like, in terms of our system planning for recovery. And also we're thinking about how we work with our communities to sort of co-design resilience programs that might support people as a follow-on from the sort of campaign, really, to think about how what's initiatives that would really help people and support people in their own lives as families and adults and children. And we're trying to work with local authorities and our partners on that as a sort of programme for the next few months as a follow-on for this. So we will evaluate it and we can bring back a sort of full report on the evaluation and its reach over time. Thank you.
Thanks both very much indeed. I think it's phenomenal, certainly from my perspective personally. In the practice, it's becoming completely apparent the impact that the pandemic has had on people's mental health and well-being, and the fact that I think as a team, in combination obviously with our comms team, you've been so proactive about this. Feels really important. So huge thanks and congratulations to the team on this campaign. Please do pass those on. We don't normally have masses of time for questions, but we have got a couple of minutes. I just wanted to, in case anyone on the governing body did want to ask any questions of Martin and Nancy about the campaign that they've just presented. I always pause just for a moment, just in case people want to let me know. Okay, cool. I think it was very comprehensive, and thank you both very much indeed. So we are now going to move on to another project that has been many years in the making, and that is the development of the Tessa Jowell Health Centre. I think just important to flag that we wanted very much to share as soon as possible with the governing body and members of the public the progress that there's been, and just to recognise that that means that this particular video is still in draft form, so it continues to be iterated and developed, but we felt it was really helpful, given the progress has been, to be able to share some of that with you. So I wonder whether we can play the video of the new Tessa Jowell Health Centre.
This facility is a brand new facility. I'm at the health centre for kidney dialysis.
Here we look after people who have problems with their feet.
It's very welcoming. The staff in here are very welcoming.
We're currently in the gym space here.
I'm here for my diabetic check.
We are now in the Children's Services area.
Welcome to Tessa Jowell Health Centre. This is a centre that's for the whole community. It doesn't matter who you are, we're here for you.
What a fantastic new Health Centre. This is a real testament to the community, but also importantly to the Tessa Giles' vision for an integrated and holistic centre where patients and the community can come for the very best of care focused in their community.
The idea being that health is important, but it's not just about medicine, it's also about kind of a social environment, it's about the mental health and psychological well-being as well.
So, for example, bringing together colleagues who work in physical healthcare with colleagues that work in psychological and psychiatric healthcare is absolutely vital.
So recognising that, the centre's allowed us to combine all of those different aspects of healthcare. There's a whole mix of services in the building, which means we can work collaboratively and really come up with new solutions for patient care. So we're in the GP surgery area at the moment of the Tessa Giles Health Centre. And this service is for all general practice needs for our patients.
Not too bad, I did get a bit tired.
There's GPs who are doctors on site, but also we have a wide-ranging team that includes paramedics, clinical pharmacists, nurses, advanced nurse practitioners, healthcare assistants. We have a mental health specialist nurse as well. And the benefit of that is we can have a special input into all our patients' varying needs. Yeah, there you go. So 60.65 kilograms, 160. So we're really excited about being co-located here at the health centre because it's going to allow us to work really closely with all our other partners in secondary care, in mental health services, in children's services, the voluntary sector and others. And we're hoping that's going to help us create real innovative changes in how patients are cared for. For patients, that means they can hopefully get everything done in one go. They won't necessarily need to be referred up to the hospital as much for specialist input. And we're going to have the opportunity to talk about complex cases and difficult medical problems as a wider team that's going to also include specialists as part of that.
So my role as a social prescriber link worker is working with GP surgeries and about bridging the gap between the GPs and the voluntary care sector and the social. So it's bringing everyone together and kind of looking at the needs of individuals and trying to help to support them. Having all the services here in one building means I can easily access them. It means I can talk face to face to the specialists and the teams and gain information.
Our entire team has been really excited, really motivated. The brand new premises is exactly what we need now in general practice. It's transformed us as professionals overnight, really, I would say.
We're in the physiotherapy outpatient department. We're currently in the gym space here. So this is a space where we lead on classes and do individual work with patients as well. Take hold of the ball, reach it overhead. The gym is like the heart of our clinic. So this is where we get a chance to look at patients' function and get to see them moving. So we might assess somebody on one of the gait analysis on the treadmill. So we might go through some balance work on the parallel bars and also using mirrors to get an idea about their position and strength as well. We've got GPs next door, also mental health community care as well as podiatry and other services that are available in one space.
This is one of the big satellite dialysis units of King's College Hospital. Looks after patients on dialysis who have kidney failure. How are you doing now? This facility is a brand new facility where these patients can come and have this dialysis away from hospital, closer to home. Although it looks like a hospital setting is a much busier, much more intense setting with a lot sicker patients. This is a much more relaxed setting.
The patients, they don't want to go to the hospital because there is a hospital, they think they, sick patients. But here it's they're coming in the community.
This is a breath of fresh air. This is 21st century medicine. There's so much light here. It's spacious. Patients have their privacy. It's how medicine should be delivered, and that just uplifts the whole team.
Okay, I'm going to assume that that was a rather abrupt ending, but I think the vast majority of the film came across, and I hope that what everybody saw was something that for me absolutely kind of enshrines what it is that we mean by kind of integrated care and collaboration, and the difference that that can then make to patient care. It's not always possible to do that all on one site. And I think the opportunity that's been demonstrated through the Tessa Jowell Health Centre is fantastic. But increasingly, of course, we're seeing across South East London new ways of working with primary care networks developing, and collaboration between community partners, social care, but also our acute trusts to start to develop new opportunities that I think really make the experience of care so much more seamless and reflect the needs that people have, which often are multiple and can't just be defined by a particular disease or condition or a particular service. So I think it's a fantastic testament to that and the work that's been done. There have been an enormous number of people involved in that work. I know because I was obviously closely linked to that when I was in Southwark, and I particularly just wanted to call out the work that Malcolm Hines did to lead that as the CFO in Southwark. Malcolm has recently retired, as many of you will be aware, but I know that many of the people watching this being live streamed and also many governing body members will know Malcolm and will want to acknowledge the fantastic work that he did genuinely over many years to see this work through to its fruition. And I think it's, as I say, testament to his work and the work of the group that oversaw this, the enormous amount of engagement that went on with local people to understand exactly what sort of services they felt that they would like. And we're talking a lot at the moment in the NHS about anchor institutions, the way in which service providers actually can become a phenomenal asset for their local community. This is a great example of that. So I would absolutely, in Malcolm's absence, want to thank him and note that and the incredible work that's gone on to get us to where we are today. And hopefully, as restrictions start to ease, that will become a thriving community hub. So thank you very much for sharing that with us. And I hope both of those brief presentations and showcases of work that's going on are helpful, as I say, for the governing body to see, but also those who are watching via live stream. We're now going to move into the next part of the agenda, which is principally around providing an update on the work that we're doing in response to the pandemic. And we will hear some presentations and have a short video as well from Kevin Fenton. But in the first instance, I was going to hand over to Angela Barn to talk about the current response status in relation to the pandemic. Thanks, Angela.
Thank you very much, Jonty. My name's Angela Barn. I'm the borough-based director in Bromley, and I'm also COVID Gold and have been for most of the pandemic. Since the May governing body, we've really continued to focus on our COVID-19 response. Although we've now come to the end of the first phase of the pandemic, it's by no means over, and the work is still ongoing. We've been working really closely with all of our partners to ensure that what we do as a response to the pandemic and as business as usual ties in very closely. So as we have progressed, we've tried to ensure that many of our activities are incorporated into our business as usual, so that we can restart electives and some of the other work that we've needed to do that you'll hear about shortly. We've continued with our close eye on the numbers, and the Gold Group has been meeting daily at 8 o'clock to review what's been happening, and also to keep a close eye on the numbers of cases and positive people testing positive. You'll be aware that we are continuing with our system leadership calls, or we have those now 3 times a week as opposed to daily, and we're stepping up some of the arrangements to prevent further outbreaks where we can. And this has included developing our infection prevention and control arrangements, as well as working closely with local authority colleagues, particularly on the outbreak plans, some of which you'll hear about later on. You can see from the data that as we come to the end of this first phase, we've had around 7,500 cases of COVID-19 in South East London. Now, these are, of course, people who've tested positive. There have probably been a number of other cases where people haven't had a test or been tested through other routes. We have sadly had 1,616 deaths, and there has been a differential distribution of that across the South East London boroughs. It probably reflects some of our differences in population, differences in age groups. So Bromley, for example, has the highest number of older people. Then where we know some groups of people are particularly vulnerable, such as the BAME groups, we may well have to see higher numbers of deaths in those groups. So I'm going to hand over now to Christina to talk a little bit about testing. What I will say is that we will continue to keep a really close eye on the numbers of cases, so that we can make sure that we are alerted early to any outbreaks or increase in numbers of cases. So I'll hand over to Christina now. Thank you.
Thanks so much, Angela. If you wouldn't mind going to the next slide, that'd be great. Yeah, so as one of the pieces of work we've been doing as a South East London CCG, but coordinating on behalf of the whole ICS, we've been leading on some work to support testing. And this falls into 2 categories. One is antigen or PCR testing. So that is the swab test to confirm whether individuals have COVID-19 at the time. And then more recently, we've also been supporting on antibody testing, which is a blood test to check whether people have come in contact with the disease. I'll come back to that in a second. Just in terms of the antigen testing, certainly the committee and many of the people watching may have seen that there has been a real increase in the availability of testing through national means. So there's now a website where people, not only employers, but also people can self-register for a test if they have symptoms. Basically, anyone now over the age of 5 can do that directly. Previously, we were actually coordinating a lot of that testing, and we've still made available through NHS capacity the ability to test. So if, for example, an individual, a staff member, for some reason is not able to go through that test, we are making that available. The numbers that you will see on here in relation to antigen testing are other tests that we are offering, as I say, over and above the national capacity. So that includes anyone who there's testing that's going on in hospital, but this is more to do with, for example, before people enter care homes, we've been supporting with that testing. And also we have been running a programme jointly with our local authority and public health colleagues to make sure that every care home in South East London has had what we've referred to here as blanket testing. So we've been testing all residents of the care home. So that's an asymptomatic testing programme. Just an update from the slides as they were shared last week. We have now tested every care home in South East London. So that includes the one Lewisham one that's referenced there. And also there is now ability to test and a request to do regular testing through the national portal. So we'll kind of continue to support that process. And we've also been looking to make sure that all of the other types of care homes, so mental health, learning disabilities, etc., we can support those tests again if there's not an ability to access it through the national route. So a really good bit, I think, of collaborative working between ourselves and public health. Just quickly, in terms of antibody testing, we were asked to test as much of our NHS staff as we could by sort of beginning and middle of July. We've tested about 80%. This is of hospital staff, GPs, CCG staff and pharmacists, which is about 55,000 staff. We've tested 80% of that, and I would say that although we are keeping the testing programme open for a bit longer, the other 20% are largely people who've declined to take part in the test. It is, of course, a voluntary test. It requires a blood test, and we have been really, really keen to stress, and I'll say it again here, that this testing is being used to help us understand a bit more about the prevalence of the disease and how the disease interacts with our body. It does not infer immunity, and so we've been really clear that people need to take all the precautions that they would even if they have antibodies. So just thought it was helpful to give a quick summary of some of the work that we've been doing on that, and also share, just for interest, because this information isn't yet being reported nationally, we're seeing actually about 25% of the people that we're testing have antibodies. Again, just to really, really stress, we don't yet know what that means in terms of immunity, but that will be going into national reports and assessments and help us with learning about the disease in the future. I don't know, Angela, if you want to say a little bit more, and then
yes, thank you. Just to say, in the first 3 weeks of May, before we got the full national testing for care homes underway, we did do the care homes in Bromley. We offered testing to all those who had been who were symptomatic and asymptomatic in care homes, staff and residents alike. And what we showed, which was probably after the peak of the pandemic, was, and this was antigen testing, was that 9% of the residents were positive, so nearly 1 in 10, and 4.7% of the staff were positive. Now, what was more alarming, because I think this isn't data that's collected everywhere, we did actually ask people to report on whether they had symptoms or not, and we found that a high proportion of the staff who were tested were in fact asymptomatic, and in fact about half of the residents were also asymptomatic. And I think what this demonstrates is that probably older people, those who are resident and maybe a bit frail in care homes, don't always display the typical symptoms of COVID-19. So people maybe just be a little bit off their food or just have some malaise. But the importance of testing, and it's really good now that we have weekly testing for staff in care homes, monthly testing for residents, because that will allow us to identify outbreaks much earlier and take action as necessary, even when it isn't obvious that somebody's suffering from COVID-19.
Thanks, Angela, and for all the incredible work that you and the team have been doing. I'm going to move through these sort of presentational sections and bring people in for questions at the end, following Sarah and Nada's presentations, if that's okay. So can I then move on to Sarah, who's just going to talk about some of the planning that we've been doing in response to the next phase of the pandemic.
Thank you, John T. That's right. The next couple of slides really just provide governing body members with an update on progress on our planning for recovery since the last meeting. So the first element relates to the work we're continuing to do locally within South East London on the key priorities that have been identified nationally and regionally. And the first of those is to keep working through, as we ramp up our services, the implications of national infection prevention and control requirements. And that's a piece of work we're doing across all areas of service provision. Linked to that is the restarting of services and activity safely, and very much a specific and early focus on elective and diagnostic services because we had existing backlogs pre-COVID and of course increasingly significant backlogs that have built up over the last 3 months or so. Linked to that very much, building on our demand and capacity planning work, again with a whole system lens to try and make sure that we have sufficient capacity to meet demand, including clearing and reducing backlogs across the whole system. And lastly, and I think this is absolutely a work in progress, continuing to work to understand the enhanced needs that have arisen as a result of the pandemic. And of course, as we get into our recovery planning, trying to work out what we do to meet those most effectively. In South East London, we're working within South East London with system partners to develop a South East London integrated recovery plan, and that's intended much more to focus on our local recovery needs, priorities and actions with an 18-month planning timeframe. We're trying to think about recovery through a number of different lenses or at different levels across our system. So very much driven by a place context. So thinking about health and care recovery for each borough and linking into wider borough recovery plans on areas like employment or housing. And then from a population context as well. So both South East London wide and by area of provision, by which I mean acute mental health, for example, or by pathway, so elective. And this all has a number of kind of key objectives summarised at the top of this slide. So really fundamentally to be driven and take action to address the public health burden, and that is very much looking at both our pre-COVID public health needs, but also COVID related as well, and linked to that really understanding and trying to address the exacerbated inequalities that we know exist within and across our boroughs. I've mentioned already the really strong emphasis locally on a safe return to service delivery, but as part of our recovery we're also keen to lock in new ways of working, be that collaboration across partners or in relation to our actual service offer and some of the pathway changes that we've made as a result of COVID. And last but not least, we have to, going forward, find a way of living within our means, so managing all this and making best use of the money available to us as a system. And I guess in summary, that's all about trying to secure a core offer for our population that really drives equity of access and equity of outcome. We're working to quite a tight time frame on this, so as we've mentioned already, first draft borough plans will be available for the end of tomorrow. There is then the planned engagement process and review and iteration of those plans through to early September, and the objective of a fully integrated plan and South East London wide overview by the 21st of September, and a start focus particularly on translating plan to implementation or delivery plans. Just in terms of approach, to reiterate, the plans are very much being developed bottom up, so the content's derived locally, albeit supplemented by either South East London wide requirements or commitments as required. As I mentioned earlier in response to the question, we are absolutely planning local engagement once we have these first draft plans, and in line with the answer I gave, that is really intended to be inclusive, bottom up and co-produced with the public, communities and the voluntary sector. Just as a linked but slightly different issue is in relation to the review we've been undertaking on our South East London pandemic response. So we have been working on a series of after action reviews, and those are very much intended to help us learn lessons, inform our future planning and ensure we're in a really good position to stand up a robust response in the event that we have subsequent COVID phases. So we've been involved as a system in London after action reviews. We have been doing a review of our own South East London response, including the work undertaken by our Incident Control Centre and our associated work streams. And we've also just commenced our usual winter planning process, but that will be enhanced this year with work to assess the work we'd need to put in place to support potential phase 2 pandemic during that period as well. So we've just started that process, and we'll be working through our local urgent emergency care boards to bring that planning to a close over the next 4 to 6 weeks as well. I guess just the final bit to note is, of course, the NHS is just part of much wider planning around the pandemic, both in terms of future potential responses and recovery. So we are involved as a system in London-wide transition planning, but also our 6 boroughs and their local outbreak planning mechanisms too. And I will leave it there and hand over to Nada.
Thanks, Sarah. We're going to actually just briefly before that show a video, but thank you very much indeed, because I think it's apparent from your presentation just how much work goes into trying to think about this and ensure that the system is ready, both for any further outbreak, but also, of course, to the to the non-COVID impact that there is associated with the pandemic as well. So we will come back to questions on that. One of the things that has been raised through both public questions, but also the governing body quite rightly, has been the impact that the pandemic has had on inequalities, and in particular on our BAME populations. Kevin Fenton, who many of you will know because he was Director of Public Health in Southwark until quite recently, is now the Regional Director of Public Health, working with City Hall and NHS England and Improvement, and has done a huge amount of work on this. He was kind enough for the Southwark Borough-based board to record a short film that describes some of his findings and actions, and I thought it'd be very helpful just to show that before we come to Nada, because I think it captures a lot of the work that's been done and the understanding that there is around the pandemic and the impact on particular communities. So I'm going to now play that video before we come to Nada. Thank you.
Hi everyone, it's Kevin Fenton here. I'm the Regional Director of Public Health for Public Health England, as well as NHS England. And it's my pleasure to be able to join you, even briefly, to do a little bit of reflection on where we are with the COVID pandemic and its impact on Black, Asian and minority ethnic communities. Now, many of you are aware that I was asked by government to lead a review on behalf of PHE of the impact of COVID on Black, Asian and minority ethnic communities in April of this year. 2 reports outlining the findings of that review were published during the month of June. The first was an epidemiological review, which clearly confirmed that we saw disparities in the impact of COVID, both on testing, the likelihood of being diagnosed and diagnosed with severe disease, the impact of severe disease, as well as mortality across various racial and ethnic groups. We saw, in addition to the ethnic disparities, other disparities which were described, including differential impact of age, socioeconomic status, occupation, as well as its impact on minority and other migrant groups. So the first report really confirmed that COVID not only identified inequalities, but also exacerbated inequalities within our communities across the country. The second report that we published looked at some of the contextual factors which drove the impact of COVID on Black, Asian and minority communities. Why did we see these differences, and what might explain actions that could be taken to inform and address these issues? Now, we interviewed more than 4,000 people through stakeholder engagement sessions over the 6-week period. We also undertook a literature review, and these confirmed that there were 4 key areas where risk experienced by Black, Asian and minority ethnic communities were likely to be increased. The first was the sort of background social and economic conditions that communities found themselves in prior to the COVID pandemic, which were exacerbated once COVID arrived. So issues such as poor socioeconomic status, overcrowded housing, the types of occupations that BME workers were likely to occupy, all had a role to play here. There were key factors that increased the risk of being diagnosed or exposed to COVID. And again, these included factors related to occupational risk, but also ways in which BME communities connected as communities, but also interface with the health service. The third area related to factors which increased the progression to severe disease and death. And this really had a lot to do with pre-existing multiple long-term conditions and how well or how poorly they were controlled among communities, but also how patterns of health-seeking behavior could have a huge and detrimental impact on your clinical course and fewer diagnosed late with severe disease and then progressed to death. Finally, the report identified a number of the structural and social conditions which underpin risk within Black, Asian and minority ethnic communities, and factors including structural racism, discrimination, poor conditions within the workplace, stigma and fear were real for many communities. Finally, both reports highlight 7 key areas which are really critical if we are going to be addressing this issue of reducing the risk of COVID among BME communities. The 7 recommendations include 3 which focus on cultural competency, ensuring that the messages that we're putting out for COVID, as well as wider health promotion messages, are engaged with communities, are language appropriate, and are culturally sensitive. So this issue of cultural competency was a key aspect of what we need to do. Second, we need to ensure that there is good data on ethnicity across all aspects of our health and care, but specifically as we are responding to COVID, to ensure we had the correct information. And then finally, there were a number of recommendations which related to ensuring that we keep ourselves to account, both in terms of the delivery of our health and care services by looking at the work that we do with equity audits, training and capacity building on inequalities, and ensuring that there are measures in place to track our efforts to reduce inequalities. And finally, as we focus on recovery, to ensure that we are designing and planning for the recovery of our services with health equity at the forefront of our planning and not as an afterthought. Now, I don't have enough time to go through all of the recommendations, all the findings of the report, but I hope that gives you a sense of 7 key things that we can do in the short term that can have a significant impact on reducing the risk to minority communities in the medium and long term, and which can set a foundation for us to do better, to have greater impact, and to help to address and reduce inequalities. So thanks again for inviting me to give this brief summary, and I look forward to my continued work with you and my colleagues in Southwark. All the best. Thank you.
Great. I think really important. I spoke to Kevin, and he was very keen that this was also shared with South East London, and obviously there are many people, as I say, who have done a lot of work with Kevin, and I appreciated the I guess the very clear set of recommendations, and I know the governing body is doing a huge amount of work. We reflected on it briefly earlier in the meeting. Under the leadership of Farouk and Joy and Christina and the Equalities Committee, to think about how we incorporate those recommendations into the work that we do, but also how, as an organisation, we demonstrate significant leadership within the local system around this issue as well. So I really appreciate Kevin having taken the time to do that, because he has condensed an enormous amount of work into that short video, but I felt it was really helpful to share with governing body members. And I'm now going to invite Nada to just offer us, just finally in this section, some of the work that's been happening around public health in response to the pandemic.
Hello, thank you, Jonty. I'm Nada Lemick. I'm Director of Public Health in Bromley, and I'm also Public Health Representative on the governing body. I have a next slide, please. What I would like to talk, just give you a brief information about the current COVID situation in South East London compared to London boroughs, because we had a lot of information about our data, and then talk about outbreak control plans, which are really important documents recently published. Next slide, please. So just very briefly, this puts our data in context in terms of London. You can see all the red are showing different boroughs in South East London compared to London boroughs. So this is our position in terms of number of cumulative cases. Next slide, please. And this just shows the rate per 100,000, again, for the 6 boroughs. Thank you. And again, cumulative number of deaths by our boroughs compared to London. Thank you. Next slide. This is an area that I would just like to spend a little bit more time with. It's the outbreak control plans. We have been all asked, London Borough's public health teams, to publish outbreak control plans by the end of June, and all 6 of our boroughs have done that. Now, outbreak control plans are a type of a framework that gives us a way of managing the pandemic locally by local boroughs. What is important in that document is that it actually provides and distinguishes responsibilities between the agencies, because what has been happening, I think, over the last few months, we have all been looking at who has what responsibility and what has to be done. This is particularly true in terms of public health, because as you probably know, public health function is split between the local function, which sits in the local authority, and the national function, which sits with Public Health England. So understanding the responsibilities between the agencies and how we work together was very important. So each of the outbreak control plans defines that, but then it has also detailed plans about the local control measures. And those are the measures in particular in terms of test and trace program, how local teams work with Public Health England teams, about outbreak management, again, what are the roles for individual teams, and very importantly about the prevention measures. And this is specifically where public health teams, the local public health teams, would lead on. And I'll talk a little bit more about this in a minute. And finally, there is a big section about governance and insurance, about data management and legal background to all these processes. Next slide, please. Now, this is maybe a little bit small so you can't see, but this is really important one about roles and responsibilities, and I briefly summarize it. It shows what is the role and what are the roles of Public Health England, where is the lead for various outbreaks in where Public Health England leads and when the local teams lead. And you can see at the top of the slide are listed various complex areas, and these are the complex settings where Public Health England will lead and local public health teams will support. And if an outbreak is a community outbreak with community clusters, this is where local public health teams will lead with support from Public Health England. And there are details about how will that work, which are outlined in the slide. And I think this was really important for us, and the plans clarify and has detailed action plans for individual settings, which are then followed by protocols for individual settings, standard operating procedures, and processes going down to very small individual areas. Thank you. Next slide. Now, each outbreak control plan has these 7 areas. We were asked, these are the areas that each plan has to cover. So, of course, important settings like care homes and schools. We've been talking a lot about care homes, and you know that there has been a lot of work done in South East London even before those outbreak plans were published. And I think it shows our joint working between the NHS, social care, primary care and public health. And overall, I think in South East London we have done really good work with care homes in terms of prevention in particular and management of outbreaks. We are now doing quite a lot of work with schools. I have been doing in preparation for the next for the new school year and potential for any outbreaks. There are other high-risk places and locations which individual areas have identified within their local plans. So that could be depending on the area. There could be specific settings, workplace, factories, or so on. Local testing capacity is important. Christina has mentioned earlier about the work we've been doing locally in South East London. So we have increased, and we have quite significant local capacity that Christina mentioned. And also we have been now asked to look locally within individual boroughs how we can increase capacity if needed. There is a plan, national plan, that we could use if need be. Mobile testing units, so Directors of Public Health will have an opportunity if need be to request the individual mobile testing units to support testing if in the case of large outbreaks. Data is another one which is a really important area, because for us in public health we always collect the data. The health surveillance is one of our key functions, and to be able to to have some early warnings in terms of our areas. We have set up, each individual public health team has set up something we call data hubs, where various data sources are collated, analysed, trends are monitored, so we can spot if there is anything happening locally and when we need to intervene. Contact tracing is another one, which is obviously how we link with the national contact tracing process, and where is the role of local public health teams in terms of jointly working with Public Health England team. The 6 areas vulnerable people, this is very important, and we have been in last, I would say, months or so, working specifically on identifying vulnerable groups, special communities that may need extra support, and trying to do a lot of preventative early measures in terms of now when we have when the disease is at a lower level. So we are hoping to use this period to push our messages across, simple messages still about infection prevention and control, but also other messages in terms of what to do if people have symptoms, to immediately ask for testing, to be tested, and equally if they're identified as a contact, then to follow the guidance given by Public Health England if they need to self-isolate. In terms of vulnerable people, also local authority teams have in the past set up systems of volunteers to support vulnerable people who are shielding, and we are now expanding this system or using this system that is in existence in local authorities to support vulnerable people who may need to self-isolate, for example, if they are unable to do it on their own, if they need help with food, with medicines, or whatever, the system will help and support them. And the final one is local boards. This is in terms of governance. So each local team has the process of governance in terms of how the outbreak plan is being developed and executed. It goes through a majority, there are slight differences between the boroughs, but majority use Health and Wellbeing Board as one of their public facing board in terms of their local governance, and Health Protection Board as a more specific local professional board to manage the outbreak control plans. Next slide, please. And finally, I wanted to say something about the joint work in South East London. A lot of colleagues before me have mentioned how we have done a lot of work between agencies across the boroughs, and I think obviously COVID is such a this pandemic has been such a difficult pandemic, but on the other hand, I think it has shown some examples of really good work across. Public health teams have been working jointly for many years, and this is of course now in this particular situation has been strengthened further. We have South East London Directors of Public Health meet weekly. There is a sharing of information, best practice. We share the data, so continuously communicate, because virus doesn't know obviously borders, and likelihood of having a cross-border outbreak is equally high. Public health teams have started to work on impact of COVID, and some of you might have heard about this, and this is led by a colleague from Lewisham, and the work has started in terms of looking at local inequalities that has been exacerbated by COVID, and also looking at evidence and what do we know, what interventions work, and how can these inequalities be addressed. So that will be, we're hoping that this work will be published and finalised by September. And finally, there is a joint work on South East London Joint Strategic Needs Assessment. Again, 6 health intelligence teams are working jointly to develop a joint South East London JSNA work. There's also a lot of joint work in between professions, and we have our joint group with borough directors of health social services, and directors of public health that also regularly meet. And this is particularly useful because, of course, this is where we get links with other areas, like with acute services. Again, this is sharing of information, data, and joint work on testing, as Christina mentioned earlier. I shall stop here, and I shall. Thanks.
No, that's really, really great, and you've covered a huge amount of ground. So time is relatively tight. as ever on these agendas, but I did want to just open up perhaps to a couple of questions. It's probably going to squeeze Andrew's report a little that's coming next, but I think Saba, you wanted to come in.
Yeah, thanks, John T. My name's Saba Salman. I'm a GP in Greenwich and one of the governing body members on the South East London CCG. There's lots of really helpful presentations. I had a particular question around the care home pilot in Bromley. I was quite interested that actually quite a number of patients that tested positive on the antigen test weren't symptomatic, especially the residents. Do we know anything about the outcomes going forward? Were they measured? Did they later present? Do we know?
May I answer that? So thank you for that, Saba. It's a really interesting question, and we did want to go back and retest, but events overtook us and the national system came in, so we haven't done that re-look now. But we are looking at what further information we need to collect. I have to say that a lot of the testing was done, as I think I mentioned, after the main peak of the virus. So I suspect a lot of the positive patients were patients who didn't need admission to hospital or going on. But I think we will try and confirm that in the future. Thank you.
Thank you. Thanks.
Thanks, and it was really helpful work actually in informing, quite early on in informing what we were doing in South East London, Angela, so thanks for having led that care home pilot. Joy, I think you wanted to come in.
Yes, thanks very much, and thank you for the presentations. I was really just asking about the speed of getting the results of the tests back. Anecdotally, I've heard that the time is getting shorter and shorter, and clearly the closer we can get it to the test, the greater chance we have of stopping spread. But I just wondered if we had some views as to whether, particularly, well, all of them, the public, the patients and staff, just how fast they are getting them back now, and if we're really clear that that's fast enough.
So, Christina, you know all that is testing. What would you say?
Yeah, so in terms of test results, initially there was a big discrepancy between the results turnaround time for what we were delivering locally, which has always ranged from some tests have even been delivered in 12 hours, but usually kind of 24, 48, and then the national testing route, which was actually much more like 72. The majority of test results are now within 24 or 48 hours, which is great. Obviously that is much quicker. They're texted to individuals in the majority of times, so people are getting that result directly, which is really, really good. One of the things that is being looked at within hospitals as part of our winter planning is rapid testing, which some people refer to as point of care testing. So there are some machines that turn around results in just a few hours, but obviously kind of the ability to run those tests is expensive, is challenging. So we'll have to kind of limit the use of that. But there is an ability to shorten that time even further for those people. But in general, public are getting results in sort of 24, 48 hours.
Thank you.
Can I just add about that patient testing, point of care testing? The machines will only allow up to 4 tests an hour, so it's not useful for wide scale testing. There is an issue with them.
Thanks very much indeed, Angela. And thank you for all those presentations. I know time is tight, so we are going to need to move on. Equally, I know that governing body members, we have been having seminars, so are up to speed with a lot of the work that's been taking place. And of course, the borough-based boards have all met, and I know many of these conversations have been had there as well. So I hope people feel well informed. Again, just a huge thank you to the team who have been working as part of the particularly the gold and silver response teams across South East London, who've been coordinating a lot of this work. The CCG has been deeply involved in that, and you've heard from a number of people who are leading that work. And it's hugely appreciated, and particularly I think the approach that Sarah flagged around the way in which we are rapidly trying to learn and ensure that we are ready for further spikes in the pandemic. I think that approach to ensuring that we absolutely understand the impact of the first phase of the pandemic and we can apply that learning feels to me to be incredibly important. So I'm certainly very appreciative. I should flag, of course, that not all borough-based boards have met, but most of them have. I think Lewisham is still to meet on the 28th of July. On that note, I'm going to hand over to Andrew to give us the Accountable Officers report. Andrew.
Thank you, Chair. Can you hear me? Yeah. Okay. Thank you, Andrew Bland. I'm the Accountable Officer for the CCG and the ICS lead. I'm going to take the report as read. I wanted to draw out 2 or 3 things from it, 2 mainly, and then I wonder if I might, Chair, just pick up a couple of the questions that we weren't able to deal with from the public at the beginning of the meeting, but I think are pertinent to part of my report, but largely take it as read. So the 2 things I wanted to call out, firstly, we turned our attention, as well as to COVID, to the impact on BAME communities, and that's been littered throughout this agenda this afternoon. We wrote to our staff to make clear our position, particularly in respect to the Black Lives Matter. Obviously, 2 months has passed since our last meeting. It feels like a lot of things have happened globally, and certainly in the capital in South East London. So we wrote to our staff in the first of those 2 months and made public our position, which I hope people will have had a chance to have a look at as an organisation, as a CCG. So that is the first thing I want to say, and just place on record the importance that we place on that. But equally, for those people who had taken interest, and a lot of people had, in our long-term plan response ahead of the pandemic, we had majored on inequalities as a key priority focus for this CCG and for the wider ICS. Secondly, I mentioned some newcomers to the organisation and to the health and care system, so I won't read those out, but I did want to note those. And then finally, I just wanted to pick up and not repeat Sarah Cottinger's report particularly, but just in terms of recovery planning, and link that to a couple of the questions I think I saw come in at the beginning that referred to David Sloman's plan, David Sloman being the London Regional Director for NHS England and Improvement. So being careful not to repeat Sarah's update on recovery or COVID response, but just to give a bit of clarity there. So I don't think there is such a thing as David Sloman or indeed London Region's plan, but they did publish a set of expectations and areas that they felt organisations in health and care in the capital should respond to. So as such, I don't anticipate a publication of a response to that set of expectations. What I do expect, however, and we've committed to, is that, as alluded to in another one of the questions, we will have draft local recovery plans that we are looking to sit alongside and create a South East London recovery plan as an ICS draft, as people have called out at the beginning, by the end of this week, but in a fit state for publication by the time as we get to the 28th of August, or more specifically for the first paper distribution of one of our borough-based boards, prime committees of this CCG, and importance to the wider partnership. So I forget who is going first, but I know the first borough-based board is in that first week of September, and then they run throughout September. So the degree that we'll be making a publication of our response, that is very locally driven, as Sarah has said, and that will be in that timescale, so the end of August. There are other features of the regional expectations, which of course we have sought to respond to previously. I don't know that they constitute published plans, but rather responses to really quite important things that Angela and colleagues have touched on. So going back to business as usual elective surgery in each of our hospitals, for example, or ensuring that we are well prepared for a second wave should it occur as an NHS, and I could go on actually, but things that that bring a good response to recovery in our providers, predominantly providers of all kinds, and preparation for next phases. But they are responses. I wouldn't characterise them as plans. Our recovery plan as an ICS and all of its parts and places, being boroughs, is at the end of August. I think, Chair, I will leave it there if that's okay. And obviously, if there are questions, you will see that we have, as well as giving photos of everybody, giving them the opportunity to update on their areas as well.
Thanks, Andrew. Yeah, I'm really enjoying the fact that we now illustrate the report with people's photographs. I think it's really helpful, just in case I forget. So thanks for that. That's a really helpful update. I will, of course, just open up to governing body members in case there are any particular questions on the Accountable Officer's report before I move on to the report from the Prime Committees. Did anyone have any particular questions they wanted to ask Andrew? I'm not seeing any hands go up. So in that case, Andrew, thank you very much indeed. That's great. So Christina, in that case, can I move on to the report of the CCG Prime Committees, recognising that obviously there's a huge amount of work that takes place outside of the governing body, and it's important that governing body members are appraised of that, and ask you perhaps also to highlight if there are any decisions that we need to make as a result of recommendations from those committees.
Yeah, absolutely. Thanks so much, Jonty. So I think it's important to say that whilst we're taking a staggered approach to re-establishing our governance, which all CCGs are doing in light of the ongoing pandemic, actually all of our prime committees have or will meet in July, and that includes, it's been mentioned already today, but the first round of our borough-based boards, so we had a number of them happening earlier in the month. We've got one, Lewisham, still to go. And much like this governing body and the Primary Care Commissioning Committee, we've been streaming those live, which gives people an opportunity, members of the public, an opportunity to both watch and participate, which I think has we've had some really positive feedback on, and thanks so much to everyone who's contributed to that. Just in terms of other committees to note, the Equalities Committee has now met, and we, as each of the boroughs, along with their local care partnerships, are hugely committed to the equalities agenda. We've mentioned it a couple of times already, but we can't, I think, too much say that. So that committee will be working hard to make sure that we have some really clear and effective actions identified that the CCG can undertake, but also ones that we can work with our partners on. I also just wanted to note that the Engagement Assurance Committee isn't yet established because we're actually engaging on the best approach to the committee. So there's a number of conversations happening at the moment, and there's been a question on that which I'll let Joy come to when we come to the public question session later today. But we are deliberately conducting an engagement piece up until the end of July, and then use the recommendations to make sure that we shape that committee appropriately. But just in terms of what we need to consider today, items for governing body approval, there are two things. One is related to remuneration committee, and so like previously and is appropriate, we will take that in the private session. And then the only thing really for this committee, unless anyone has any questions, is that as part of our first commissioning strategy committee, there were some really minor tweaks made to the terms of reference, but as part of the process, we just need to get them endorsed here, and that paper with the track changes is included in the papers.
Thanks, Christina. So in that case, I just want to ask governing body members first whether they have any questions in relation to the work of our prime committees. Again, I'm not seeing any hands raised, and many of you, of course, will have been involved in those committees and the decisions that they've been taking. In which case, can I just ask any governing body members to indicate if they do not support the recommendations made in relation to the changes in terms of reference for our commissioning strategy committee. Okay, I'm therefore going to assume that those changes are supported by the governing body. Thank you very much, Christina. That's great. We will now, as again, I think so people who have been present at our previous meetings as well know it's incredibly important as a governing body to us that we kind of hold quality at the heart of everything that we do. And so we do have a specific update, and I hope we'll do at every meeting that we have around the work the CCG is doing in relation to the quality of care local people in South East London receive. And in Kate's absence, I understand that Sonia is going to be kind enough to present that today. So Sonia, can I hand over to you? You may wish to introduce yourself. You're on mute though, so I think, yeah. Have we lost Sonia? It's possible that we have lost Sonia. I'm not absolutely sure. Can I just check? Sometimes there are gremlins in the technology, so just let me double check. Let's just move on to the BAF paper and we'll come back to Sonia. I think that's probably most helpful. Oh, because I'd actually skipped it anyway. I don't know how I'd done that. That's my fault. I do apologise. Sonia, I'd managed to skip the BAF paper, so we're going to go to that first and then come back to you. So Christina, Board Assurance Framework. I do apologise.
Brilliant. No, that's no problem. Thanks so much, Jodie. So this is the first airing of the Board Assurance Framework at the governing body. Obviously, at the last public governing body, we approved the corporate objectives, and so this now brings back a piece of work that has been coordinated by the assurance team, but has had inputs from a vast range of people both here and outside of the meeting. So again, my thanks to that, because it does take quite a bit of work to kind of put these things together. The BAF identifies 25 risks for the board to consider. Obviously that is a lot and it's a high number to be managing at a governing body level, but just wanted to say two things on that, talk briefly on process, and then I'll open if there are questions. Firstly is we are committed to the idea that the BAF should look at risks that relate to our corporate objectives and not simply those that are of highest risk and impact to us. So this covers kind of some that might seem low but are important and fundamental to our corporate objectives. And secondly, we obviously do have a clear structure underneath the governing body of other prime committees and boards which will also be overseeing these risks, particularly the Integrated Governance and Performance Committee, and so we will make sure that we have the ability to discuss and consider these robustly. So, as I mentioned at the beginning, these were developed based on the corporate objectives. They have linked, so both the content and the risk assessments with a bit of moderating has been developed by the teams, the relevant teams, the sort of owners of these, and they are brought to this committee with the ask to confirm that people think that these do seem the right risks, that the scoring seems appropriate, and appreciate it is an art rather than a science in terms of scoring risks, but also that there seems to be enough mitigation for the committee at this time. Of course, we will continue to keep all of these things under review at a detailed level, as well as bringing updates and reports to this committee. So that's all I was going to say by way of intro.
Thanks, Christina. It's really helpful, and as the governing body knows, this is an incredibly important part of our work and the ongoing work of the teams across the CCG in monitoring risk in terms of the objectives that we have set. I wonder whether there are any particular comments or questions from the governing body. Mary, you may just want to make a comment, perhaps.
Thank you, John T. It was just to say well done to the team, really. I think it looks a really comprehensive document. I've seen many BAFs in the past and I read this one. I was really pleased. It looks good. Thank you.
Thanks, Mary. Perhaps worth just introducing yourself as well. Sorry, I should have suggested that just so that those watching are aware of your role and who you are.
Yeah, sorry, that's my fault. So yeah, I'm Mary Curry, the registered nurse on the governing body. Thank you.
Thanks, Mary, and thank you. I can completely endorse your comment, and thanks to the team. Simon, I think you were also going to pick up a question on the BAF.
Yes, and without going into too much detail, just sort of two quick questions. One about
some of the risks we've actually reduced, not just the likelihood, but the impact, and just perhaps a little comment on what that has been. So I should introduce myself to, I'm Simon Mackenzie, I'm the Secondary Care Doctor Governing Body member, so apologies for not starting with that. And the second thing does relate to secondary care, which is for quite a few of the acute targets or standards. It's clearly been a very difficult first quarter because of COVID, and I just wonder whether there was any intelligence on where we were likely to be with those, accepting that these aren't questions they're probably clear answers to at the moment.
Did you want to pick that up, Christina, and then I'm going to bring Joy in, I think.
Well, just to the first part, and then I think Sarah might want to comment on the particular risk. So in terms of mitigating the changes to the risks and impact, I think really helpful to have the scrutiny and discussion. In theory, of course, the impact scores should reduce if we think the mitigations are going to mitigate the impact, but it's really helpful to have that feedback, and thank you for sharing it in advance. I've had the team kind of pass it on to the team, and they are having a look at that as well.
Thanks. So Sarah, did you want to pick up on the second part of that?
Yes, thank you, John T. I'm not sure I can give a very definitive answer to Simon's very valid question. I mean, I think we are in very exceptional and unusual circumstances. Of course, all the start year work we've done to agree performance delivery targets has gone on hold. And of course, in some areas we've had a performance improvement during COVID. A&E is an example, in others a deterioration, so RTT and cancer. I think, therefore, we need to recognise this as a first BAF, and particularly for those acute targets, we all need a process of iteration and further work, particularly, I think, in the context of our imminent phase 3 national planning guidance, which I think will be much more explicit around expectations and give us clarity as to the targets that we should be working to. I then think we will need to have another go round this BAF for those targets, because that could fundamentally change both the risks and the potential mitigations and therefore impact.
And John, to just say thank you for those responses, and I've offered my support around trying to interpret some of the secondary care stuff, if that's helpful given my background.
Yeah, really helpful, Simon. Thank you. So if I can then also bring Joy in, please.
Thank you. My question was just around number 24 on the BAF, and overall I think it's a terrific. I echo Mary's comments about it. It's just after we've been hearing all the work that's going on and the issues around inequalities. We've got number 24, delivery of the RES, and presumably that's the workforce race equality standard. And next year there'll be the workforce disability equality standard, and presumably we'll bring that in. But I just wonder, we've got here likelihood 4 times impact 3. Actually, I've just realised the sum doesn't work out right at the end as well, but we're aiming to get the likelihood down to 3, but the impact's still 3. And I just wonder whether the impact of 3 is high enough at the moment. From my point of view, I would think it would be at a 4.
Thanks, Joy. Yeah, really valid point. I mean, obviously with everything that is going on the equalities agenda, it sort of feels like these could be, every equality risk could be a 5, because it's such a hot topic. But I think the reason for the scores at the moment was there were sort of similar scoring. We have actually in previous years managed had relatively good outcomes, definite room for improvement in terms of RES, just kind of comparatively, but absolutely I think that's a completely valid point and probably is worth looking at. And I did wonder whether we should at the next equalities committee have a proper robust conversation both about the risk score, but also just to make sure that we've got all the mitigations in there that we really think will make the difference.
Yes, I'm quite comfortable with that, thank you.
Great, thanks very much indeed. In that case, I think I can't see any other questions coming up. Thank you very much, Christina. And I think just to reiterate Mary's support for the work that's going on with the BAF. Thank you very much to you and the team for that. Okay, so second time around, I've already talked about the importance of quality. So Sonia, are you happy to update us with a quality report?
Yep, can you hear me now? Just checking.
Can indeed.
Thank goodness. So my name is Sonia Colwell. I'm one of the 2 directors of quality working to Kate Moriarty-Baker as chief nurse, who unfortunately is not here today. So I've given a brief set of slides in the pack, which I assume you have read. So I will just pick out some key points. First of all, to give assurance to the governing body that the quality surveillance is ongoing through this difficult time. We've had really good collaboration with our providers to ensure that quality and quality surveillance is ongoing, obviously at a reduced aspect to that, but it has still been going on. Okay, next slide, please. We've held our first Quality and Safety Committee, which has a number of governing body members on it, and that's chaired by Mary Curry. So I think that committee will hopefully continue to develop, and will working hard with our providers at the moment with a data set. Bearing in mind we are very conscious we're moving towards an ICS way of working, so we're very much doing that jointly with our providers. Simon, can you move on to the next slide? Thank you. We're working across South East London already on a number of things which have been highlighted on that slide. Looking at SIs once across the system, a single quality impact assessment, and so on. And this is in preparation for what will be coming to at some point, the development of a nursing and quality directorate, which is very much building on the work and the way we've been working together during COVID. Next slide, please. I just wanted to highlight to you the CQC result from Lewisham and Greenwich Trust. And although this requires improvement overall, there has been an increase to good in a number of areas highlighted in the report. And I think talking to the CQC, they have really recognised the enormous hard work by the Trust and colleagues in the system. And obviously we're working with them to continue that journey of improvement. Okay, next slide. Number of SIs, serious incidents, are still coming through from our providers. We have reduced, in line with national guidance, the root cause analysis production, but in fact actually our providers have still continued to do this throughout. Perhaps rather sadly, and linking up with the presentations we've had today, you'll see on that report that self-harm is clearly showing as one of the significant reasons behind a number of the serious incidents. And we're beginning to see now, as some of the later reports come through, the impact of COVID, and we will obviously do a thematic analysis and feed that into all of our recovery planning to make sure that lessons are learnt. Okay, thank you. And then a few slides there on safeguarding, which I'm not going to go through other than to give the governing body assurance. Safeguarding was never stood down, as you know. Safeguarding colleagues, designated doctors, nurses, named GPs have been working really hard supporting our provider colleagues. And I think picking up on what Nada said, I think the work, particularly with children, but with adults as well, working with our colleagues in social care with really regular meetings has been particularly valuable throughout this COVID period. And I think that will obviously continue going forward. But we are seeing, many cases of deteriorating mental health, many cases of domestic abuse, particularly in people's homes, not necessarily people known to social services previously. And then finally, on the last slide, the work that we've been doing with others supporting the care homes. So that's a brief update for you, Jonty, on the work of the quality team.
Sonia, thank you, and massive thanks to the team, because I think we are not only having to manage the pandemic, but as I think you've alluded to, we're establishing new structures and processes across South East London to ensure that we do keep quality at the heart of what we do. A lot of that is built on relationships and soft intelligence and understanding what's happening in the system, and it's something that I think I certainly see as being a great strength in the approach that we take. And the other thing is a lot of it very much relates to close collaboration, which it always has, but I think increasingly as we move towards an integrated care system, it's fantastic the way that we're trying to adapt and understand how we work collaboratively on some of these challenges that we face across the system. So incredibly helpful from my point of view. So on that note, I think Simon, you were just going to come in with a question.
Yeah, thanks, Sonia, for a very good report and all the work that's going on. Just a question about COVID-themed SIs, particularly in acute care. Obviously, there's concern about what the self-harm may reflect on that, but there's been a lot of noise amongst the clinical community about having to work with reduced staffing levels and in unusual circumstances and with equipment that people wouldn't choose. But there seems to be very little come through in the way of SIs around about that. And I just wondered whether there was anything worth picking out for future learning for any further surges, or is it too early to say?
It's definitely worth picking out for wave 2 or beyond. They're just starting to come through now, so some of it we're picking up in the 72-hour reports, but the SIs, as they're declared, as you know, they can have 45 to 60 days to respond, and we've been quite relaxed about that during this pandemic phase. So we're starting to see them coming through that, and certainly staffing and equipment are looking like themes.
Thank you.
Thank you. Yeah, absolutely. Thank you. I think Neil, you also wanted just to come in.
Yeah, thanks very much, Sonia, for your report. Neil Kennett-Brown, I'm the place-based director for Greenwich. I just wanted to really commend Lewisham Greenwich Trust for their improvement as seen through the CQC report. Whilst the overall rating does requires improvement, I think we have seen some real significant improvements. I just really want to commend them for particularly areas like critical care, which were actually quite criticised in previous reports and now is actually deemed outstanding, as is surgery on the site. And I think as kind of the local team, we've really seen some improvements through the trust. So it's encouraging to see their progress, and we will support them on addressing the issues going forward, some of which link into areas like mental health and requires us to work really closely with Oxley's, which we're doing, and SLAM for the UHL site, just to make sure that the flow of mental health patients through the hospital sites works effectively and safely. So thank you. That was the only comment I wanted to make.
Really, really helpful. I don't know if you wanted to add to that, Sonia. I think really helpful, and as you say, so many of the challenges that we face require us to work collectively to address them, and I think that's really the value of the progress we're making towards integrated care. Sonia, thank you very much indeed. In Kate's obviously having a well-deserved break. Thank you so much for presenting on her behalf and for the work that you and the team are doing. Can I now move on to the next item on the agenda, which is I think, Angela, you're going to talk to us about individual funding, the individual funding request policy. So can I hand over to you?
Thank you very much, John T. So yes, Christina and I have been working with our borough colleagues and the North East London CSU on this. During the course of last year, the 6 boroughs, the 6 CCGs, agreed that we would work with NEL CSU on a single IFR policy and process for all drugs and non-drug applications. Now, we agreed this as for a number of reasons. Firstly, it was part of a once for London offer, which means that across London, if we have a very similar process, we reduce inequalities and we are more consistent in our commissioning decisions. But also nationally, there is a requirement for CCGs to collaborate much more and to have increased efficiencies in service provision. So the launch date for this originally was the 1st of April 2020, but obviously a number of things prevented us going live at that time. So we're now proposing to adopt, recommending to the governing body that we adopt this with a proposed go live date of the 1st of October 2020. The single IFR policy will mean that we can, as I've said, work consistently across our 6 CCGs. We can release efficiencies for investment in other areas, and we can ensure that consistency and robustness of IFR triage processes. So this policy that I'm commending to you is attached to the paperwork that that went out with the papers. It includes who might be on the IFR panel. It includes the ethical framework and checklists. And we would recommend that the panel adopts this policy, and we also would like to recommend 2 individuals to be the South East London reps on the wider London panel. The first of these is Dr. Sid Dishmukh, who's the clinical lead for Bexley, and Harvey Guntrip, who's a lay member for the Bromley Borough-based board. So there's a lot of detail in these papers, and I won't go through all of that now, but I think it is really important that as a CCG, as a new CCG, we keep a close eye on how IFR applications are being managed, and we are working continuously with the team to refine the process, as well as to agree quality measures along the way. Now, we haven't finalised the monitoring of this contract, or indeed where the results of monitoring of IFRs and so on will come, but we have got these as part of the process, and we will work perhaps with Mary and the quality subgroup to look at the outputs of these processes to make sure they're as strong as we'd want them to be. I think I'd leave it there unless Christina wants to add anything.
Thank you. Christina, did you want to add? I think the paper is very explanatory.
Yeah, no, nothing for me. I think Angela covered it excellently. Thank you.
Great. So in that case, and obviously this conversation is happening across CCGs in London. So we are one of a number, but we're looking for the approval from the governing body for this draft once for London IFR policy in the first instance, and then I'll just come to the suggested representation or nominated representation that we would have on the panel. So first, can I just check, does anyone not approve the draft once for London IFR policy? Actually, I can see here I should have gone to questions first of all. Mary, I think you wanted to come in with a question, so let me bring you in first before we move to a decision.
Thank you, John. Thank you, Angela. Just to say, I really welcome this approach. I think it's sort of a long time coming to ensure we get consistency across the board. Really, my question was linked to the reporting. Angela, you called it out before you concluded. I think it's important that we know where it will be reported back to and frequency and some of that detail. I'm happy to have a conversation or link with you around some suggestions. Thank you.
That would be really helpful. Thank you very much. We can take that offline and have that discussion with Mary.
Excellent. Thank you. Thanks, Mary. So in that case, can I just, so I'll just ask again then. So let me just double check there are no other questions first. Again, I can't see any other hands up. Apologies for having missed yours, Mary. In that case, can I then just move again, just to ask if there's anyone who doesn't approve the draft Once for London IFR policy on the governing body? I'm not hearing any dissenting voices, so we will take that as approved. And can I just ask whether, again, there's anyone who's unhappy with the proposed representation? I think Sid and Harvey, if that's right. Any?
You have to keep quiet a minute.
Anyone concerned about that? No. Okay, then I am very happy that that's supported as well by the governing body. Angela, thank you very much indeed.
Thank you
for the presentation. That is great. Okay, so in that case, we will move on now to the next item on the agenda, which is the item on Lambeth Hospital Services, obviously quite extensively discussed at local level in the Lambeth Borough-based board. And I'm going to ask Andrew Ayres to take us through this before we make a decision as a governing body. Andrew, you may well want to introduce yourself and obviously any other colleagues at the same time. Thank you.
Thank you, John T. And I think we've got some slides coming up. Are the slides coming? Thank you, Simon. Yes, thank you for having us here today to take this item. This is a recommendation from the Lambeth Borough-based board around the reconfiguration and transfer of adult mental health services from the Lambeth Hospital site in Clapham to the Maudsley site in Denmark Hill. As you say, I'm joined by colleagues from both the Trust and from the commissioning team today, and my name's Andrew Ayres. I'm the Strategic Director for Integrated Health and Care for both CCG and for Lambeth Council. As you already said, John T, this has been long in making, this decision. The Lambeth CCG board has considered the proposals in the past, and recently the borough-based board, following a formal public consultation, has also considered the proposals again and is now making recommendations to this governing body. We're going to try and cover 200 pages of board papers in 5 minutes, so we're going to go pretty quick. But we have had the opportunity in the last period to work with other governing body members who would be less familiar with this Lambeth scheme. We've had opportunities to do briefing and have conversations and answer questions. So I'm hoping it doesn't come as a completely new item for everyone around the table. So having said that, I'm going to just pass on to, have we lost the slide? Simon, have we got the slide back?
I think it's up, Andrew.
Okay, thank you. I'm going to pass on to Rob Harland, who's the clinical director from SLAM Lambeth Services. Rob.
Yeah, hello everyone. So I'm a consultant psychiatrist as well as a clinical director, and I've worked on both the Lambeth and the Maudsley site. And so I'm just here really to talk to you about these first two slides. The first one is what we're aiming to achieve. So we feel that to improve patient care and experience, we must improve the quality and safety of our inpatient wards to meet the most basic needs of our patients. We're committed to supporting people in Lambeth who are experiencing mental illness or distress, and there is an opportunity here to build a new purpose-built mental health unit on the Maudsley site. So together with our partners as a health economy, we're planning for the future, and in doing this, we recognise that there is a need to consider all patients across all our boroughs, not just Lambeth. Can we go on to the next slide, please? So this is our preferred option. As you may well know, there's been a public consultation which sought views on two options for the Lambeth Hospital site. The first option was to do nothing, and the second one was to relocate 4 acute wards and a psychiatric intensive care unit to this new purpose-built facility that we're talking to you about today. A further option was considered to develop the Lambeth Hospital site, but this didn't come to consultation as it failed to meet 2 key affordability tests. This was about the additional capital that would have been required due to the loss of capital receipts, and also the disruption around a decant that would have been required while the work went on, and the greater level of efficiency savings that would have been required to service the additional capital charges. I'm going to move on to the next slide and hand over to the next presenter.
Thank you, Rob. I'm going to hand over to David Arcaya now, who's led this consultation process on behalf of the CCG, just to give a quick update on how the process has been developed. David.
Yes, thank you, Andrew. So just a key point to outline is, as has been previously mentioned, there has been an extensive pre-consultation exercise, which resulted in the pre-consultation business case being approved by NHS Lambeth CCG, subject to feedback from the consultation. This subsequently was agreed in the beginning of March, which then led into the kind of 12-week consultation exercise. And we used a range of channels to ensure that we reached into our kind of key constituencies, including patients and carers, our BAME communities and staff, and also that throughout this process we had active JOSC engagement and oversight with 3 meetings throughout the whole process. We got a range of submissions and from the key stakeholders that were identified as being important, and consequently, as part of that, we feel that there was high level of support from across the stakeholder groups that contributed towards the consultation, and the feedback generally was extremely positive. But the central focus for some of our Black communities in relation to this was the key consideration for them was making sure that what goes on inside the building in terms of the clinical offer is both clinically excellent but also culturally appropriate, and that is one of the key themes that we're going to be taking forward through in terms of the recommendations. So if we move on to the next slide. And as you can see, some of the key recommendations that came out from the themes that were identified, there were 7 key areas and themes that came out, and of those key things that were taken forward relate to both identifying how we make sure that we continue to make the site as accessible as possible in terms of travel time and travel times and accessibility. What we do in terms of making sure that we ensure support and orientation for people who may be using the site, the continued making sure that we make most beneficial use of the Maudsley site, both in terms of both the density of that site, but also making sure that we maximise the opportunities for greening the site so that the actual site is beneficial for both the patients and the wider public. And that we have some effective clinical pathways in place to make sure that there's effective integration of both the kind of community and clinical offer for patients in Lambeth. So we'll move on to the next slide. So just to outline the decision-making process, and as has been previously mentioned by Andrew, and is that this is the culmination of a long period of engagement with key stakeholders. And in terms of this whole decision-making process, the key governance as outlined is that it's been approved by a number of key stakeholder groups, which includes the Lambeth Together Board, which approved the recommendations on the 17th of June, and then further on the 17th of June, and then there was a further meeting on the 1st of July, at which we took into account some feedback from Black 5, who requested some assurance regarding the process, and as a result of that, we were able to kind of approve the recommendation to take forward. Also, the Lambeth and Southwark JOSC gave their approval to the proposals, and we are taking forward some of the recommendations for them to ensure them that actually we will continue to engage with both the local authority and our local communities over the next few months, part of the implementation plan that Sam will be putting together. And so now we're at this point today with South East London CCG in terms of taking it forward, and then subject to the CCG giving their blessing and approval, it's South London and Maudsley Foundation Trust will be taking it to their board on the 28th of July. And then
Thank you, David. And then just to conclude, next slide, please. This is what we're asking of the governing body today, to support the preferred option, and to inform the trust to to push ahead with the proposals, and then importantly to take on board those 7 recommendations we've made as the themes raised through the consultation as part of the decision-making case going forward. So that's the 2 asks of the governing body today. Very happy to take any questions from myself or the rest of the team with us today.
Thank you very much, Andrew, and thanks to colleagues as well for being so succinct, but also I think for the massive amount of work that has gone into this piece of work. And I think, Andrew, as you flagged, there have been conversations and briefings for the governing body, so this is not the first time of looking at this, and of course a conversation already at the Lambeth Borough-based board. Joy, I just wondered whether I might pass to you first, just for your reflections. Obviously in your role as our sort of lead around engagement and involvement, for your reflections as a governing body member on the work that's been undertaken, just before I ask for any other questions and move to make a decision.
Yes, thank you very much, John T. And I've certainly had additional briefing specifically relating to the consultation, which is obviously within my remit. And I just wanted to add to some of the things that David has mentioned around the consultation. Looking at it and going through it, I think it's been a very robust consultation, particularly in the circumstances that this situation was going on. It's been very targeted, which is right, looking at the types of patients that have been involved. It's been very targeted, and I thought the targeting was being excellent, and particularly the involvement of Black Thrive, who have contributed significantly because of the large numbers of Black Caribbean and Black African men that are involved. My own concern before the briefing was particularly about the numbers who didn't want to move to the Maudsley, and we talked about that during the briefing, and I've understood now. I wanted to explore a bit more about the conditions around the Maudsley, some of the responses. People wanted green space to be able to go to. They were concerned about it being in a busy situation, and various comments like that. And I've been assured around many of the issues that have been raised. So I think in summary, I think it's been a very robust consultation. As I said, I've gone through it in quite a lot of detail. I think the commitment to co-design the new service with the patients is absolutely key and crucial, and that obviously has been given. Thank you.
Thanks, Joy. Really helpful to have your assurance around that, and the fact that you've obviously reflected on that in so much detail. Are there any other questions first from members of the governing body? Peter, I think you wanted to come in. Great, there we go. Peter, you may want to just introduce yourself.
Thank you. I'm Peter Amraker. I'm the lay member for primary care and commissioning. John T, we had an opportunity to have a very detailed briefing from Andrew, David, Rob and his colleagues, and we were satisfied with all the questions raised, in particular the future proofing of the building and the fact that the built environment was taken into consideration at such an early stage. So we thank very much for the detailed discussions that we had before, and I fully support the recommendations.
Thank you, Peter. And important, I think, perhaps to turn to Adrian McLaughlin as well, obviously as the chair of the Borough-based board in Lambeth. Adrian, did you have any comments before we move to decision?
And thank you very much for doing my introduction for me. Also, at the borough level, the mental health lead, and clearly have followed this story, and you've heard, I think, from a part of the team, and just add my endorsement to what I think is a hugely important decision for us all to be taking. That this is about Lambeth people who need inpatient care in an environment that is best for them, for people who are using services, for the carers, and for staff, importantly. But obviously this sits within the broader context of having excellence of out-of-hospital services as well. But I think you've heard about the process that's got us here and the importance of something that is, I think, particularly fit for delivering excellent services to Lambeth people, and I think the joint work towards this and the importance of the cultural recognition and the appropriateness of the service that is delivered at the end of it in the new building, I think you've heard strongly already. So to add my endorsement strongly as a GP and as the local mental health lead.
Thank you very much. Thank you very much, Adrian. So can I just check, are there any other questions? I'm just looking for any other hands up. I can't see any questions. Simon, I wonder if you could just bring up the recommendations again. I don't know if you've got access to that slide, just so the governing body can see them, just because they are relatively detailed, although I think quite simple at one level. So in that case, and having heard the assurance that you have from the team and from colleagues on the governing body, can I just ask, again, we're going to do this on the negative, I think, just because it's hard for everyone to call out given the technology. So can I just ask if there's anyone who does not approve the preferred option as described in the decision-making business case to move the inpatient services from Lambeth Hospital to new facilities at the Maudsley Hospital following formal statutory consultation? Is there anyone who does not approve that recommendation? Excellent. Okay, thank you very much. I will take that as unanimous. And can I then also just ask the governing body if there's anyone who does not support the recommendations in response to the key themes raised by respondents to the consultation and contained in the decision-making business case, so these can be progressed as part of the next phase of planning by the South London and Maudsley. So those were those specific recommendations that were made. I'm looking for anyone who's not supportive of those. Excellent. So those can also then form part of the next phase of planning. So both, in that case, both requests are supported by the CCG governing body. Thank you again to the team for the amount of work that's gone into this, and I know the work that's obviously been going on locally in Lambeth. Okay, good. Thank you very much. So that is approved, and we will, in that case, move on to the final item on the agenda before we come to the public open forum, which is the finance and planning report. So I'm going to pass to you, Usman, for that.
Thanks, Jonty. Good afternoon all. I'm Usman Yazi. I'm Chief Financial Officer for the CCG. So you've got the report. Thanks for putting it up on screen. I won't go through it page by page, and hopefully everyone's had a chance to read it, but I will just highlight some of the key issues and items that I think is important for the board to note. So year to date, well, let me just start by saying we're clearly still in at month 2 when we're reporting this in the pandemic level 4 response, and therefore all our financial frameworks were based on the national guidance and the national framework that was put in place for months 1 to 4. So in terms of our reported year-to-date deficit, we were showing an £18.2 million overspend against our allocation as we'd been issued. 11.5 million of that was related to COVID costs, and we can sort of come onto that in a little bit, and I'll just talk a bit about the breakdown of what those COVID costs were. And then we had £6.7 million for our deficit was related to sort of other items, largely related to the way our allocations were changed for this month 1 to 4 period. So we have the £18.2 million deficit. I think it's important to note, though, we reported a break-even position in line with the national guidance around the month 1 to 4 financial framework for all organisations. We reported break-even on the basis that we will receive a retrospective top-up to the value of that overspend that would allow us to report break-even. I think it's worth just noting as an update at this point, we have received £11.5 million off that top-up, which was directly related to the COVID, and all CCGs have received those as sort of in the same way that providers have received all the COVID top-up funding. The balance of the top-up funding that's sort of related to the non-COVID element will be paid at month 3, in effect a month in arrears after it was being paid, so next month, and that will be the process that continues as long as the current system is in place. So then those are key things just to highlight in terms of the overall position. I think a couple of specific issues just to flag were, one of the challenges through this financial framework we've had for month 1 to 5 is, while we've been focused on the pandemic response, and rightly so, and all our effort has been sort of driving to that, especially in the early parts of the year, so in April and May, we have also now, as part of the recovery, started to look at some of those programs that we normally receive non-recurrent sort of funding for each year. So programs like the Maternity Matters, the TCP program, and I think clearly many people know about the accelerator bid that we were successful for. So we've just been working through with regional colleagues to make sure that we've confirmed those separate bits of funding. And I think this week have just confirmed with the relevant teams internally within the CCG that we have received the funding for those specific programmes, and we'll be able to proceed with those, because I know that was a question in previous months. Simon, thanks for going on to the slide about the COVID costs. So I think just in terms of this slide, I just want to highlight, I've lost it on my screen. Of the £11.5 million worth of COVID costs that we incurred, hopefully you can see the breakdown there, and you'll see that, as you'd expect, some of that relates to sort of IT, the PPE costs that we've incurred directly as a CCG, which is largely related to primary care. The majority of our COVID costs, though, have actually been the hospital discharge programme. So you'll all be aware that as part of the response, new arrangements were put in place for discharge, and including the sort of, we are covering through the CCG funding the discharge costs that the local authorities are incurring. So of the 11.5 million, 6 million of that was related to hospital discharge, and 4.7 million of that was actually hospital discharge costs incurred by local authority partners in South East London, that as part of the national financial framework we are covering through the CCG position and then claiming retrospective top-ups for. So I wasn't going to say anything else on that, but hopefully that's clear in terms of what our COVID costs were. We have just set out a slide on section 6 of the paper, that starts to look at what our run rate is. And I suppose it's just to start flagging that as we now move back into recovery, we will have to start thinking about a financial position again, and start to think about what are the actions we will need to take to ensure that our run rate, which is really what we're focused on now. I mean, given all the changes that have happened, the sort of changes to the allocations, I think trying to compare to what our previous budgets were probably isn't going to be practical for the rest of this year. So what we're sort of really focusing on is understanding what our run rate is and trying to keep our overall run rate, excluding COVID costs, to within the sort of funding envelope that the CCG was previously sort of allocated, but also reflective of where we will go next year, and sort of starting to think about 21, 22, and the fact that we can't have a run rate this year that is so high that in effect we wouldn't be able to afford it last year. So that's some of the work we're currently working through with relevant teams and colleagues throughout the CCG, but also with the region and as part of sort of our system partners as well. Just a couple of the risks, I suppose it is worth flagging. Simon, if you don't mind, just going back up to the risks page. We're clearly in a sort of unique period of time in terms of national financial frameworks sort of imposed over month 1 to 4, and sort of relatively direct control. I think it's just important that we have flagged a couple of issues there in terms of making sure we receive our retrospective allocations, because until we receive those, we are technically reporting break-even, but we're not in a break-even position. So we are sort of making sure we'll follow that up. I mean, it's a low risk, we've flagged it as low, but it is just important to note. And I think some of the other challenges we will have is when we came into this year, we did have in effect an underlying gap, and that was part of the driver for the QUIP programme. That QUIP programme is going to, I think, clearly, if people will recognise, be difficult to deliver given the circumstances, and therefore the ability to close what was a pre-existing gap. In effect, our run rate spend in all our budget areas was higher than the allocation we had received, and therefore we were going to need to make savings. That run rate has continued, without the ability to make the savings necessarily. And so therefore we have highlighted it as a risk. Again, as part of the month 1 to 4 position, it is covered as part of the retrospective top up, but once we move out of that arrangement, we will need to start thinking about how we deliver some of those programs that we had talked about last year, partly to sort of improve our position this year, but also thinking about going into 21-22 and making sure we're set up in the best possible way for the future year. I'll leave it there, Jonty. And unless people have got other questions.
Thanks, Usman, and thank you for all the work you've been doing. I know how incredibly complex it is to be managing finance through this through the pandemic. So thank you. I think Saba has a question. Saba.
Hi, thanks for your report, Usman. I was just wondering, with regards to the COVID-19 expenditure and perhaps our financial position as well, do we know how we compare to other STPs across London?
Thanks, Saba. Great question. Without going into all the details of the numbers, I think broadly all the sectors of London, so all the CCG sectors of London, had a broadly consistent set of numbers related to COVID costs. So there was a sort of relatively narrow range, and they're all sort of similar items you'd expect that. So lots of costs related to implementation of IT and new digital rollouts, sort of rapid rollout of those, PPE costs. And then I think for all sectors in London, the biggest cost was the discharge costs, and those have been relatively consistent across London.
Okay, cool. Thank you, Usman.
Thank you very much indeed, Usman. I'm just double checking to see whether there are any further questions. I think you're being let off the hook somewhat, so that just means you've done a fantastic report. Thank you. Hugely comprehensive. And very, very reassuring. And I know, again, that you have been keeping the governing body in close touch with what's been happening, so people are well informed. Thanks so much for all of the work that you have been doing on that. Fantastic. In that case, I think that brings the main business of the meeting to a close. Just before I open up to questions, the further questions that have come in from members of the public, there was a question that that I had, so I'm going to slightly take chair's prerogative to ask an additional question. I probably should have brought it up earlier, but I guess this is mainly to Angela Barn. I wanted to just ask you about the planning that's going on. Obviously, it seems a little bit strange, given that we're in July, to be thinking about the winter, but actually there are a lot of concerns being raised across the system around the potential impact of COVID across the winter months and in association with flu, and our planning around that. And I wondered whether you could offer any assurance to the governing body about our approach and our planning around that specifically.
Yes, of course, Jonty, thank you very much. It's actually not early to think about winter and flu planning, because we normally do this every year around June, July time anyway. And as you'll know, practices are ordering their flu vaccine for the next year before they've before the previous year's programs have finished sometimes. So it's never too early to think about the next flu season. Now, you're absolutely right, because of the concerns that the second wave of COVID-19 that might occur might coincide with winter pressures and a peak flu season. There is a far, far greater emphasis on and scrutiny on planning for flu immunisation and delivery of flu vaccination up and down the country, but specifically in London and the South East. In the South East, we've taken a very proactive approach to this. So each borough has a lead who's been asked to work with their practices and their primary care networks to develop an action plan. We know that there will be a number of factors that affect the flu programme this year. For example, the need to adhere to required infection prevention control arrangements. So you can't have people lining up outside practices with just their sleeves rolled up. We have to maintain some distance between patients. We also know that there may be greater take-up of the flu programme this year, so we have to be prepared for that as well. The borough-based leads have been focusing, and we've asked them to focus specifically on ensuring that there are sufficient supplies of the vaccine that have been ordered by practices, and where practices feel they haven't ordered sufficient, there's the potential to order more now. We've also focused on data recording and reporting, and that includes the identification of people who are vulnerable. As a country, we're not very good at vaccinating those people who are under 65 and at risk, but I think that's something we absolutely need to focus on. We're much better at vaccinating our older population. So it's a very timely question. This Wednesday, the assurance team, Christina and I, are meeting with all of the borough flu leads and undergoing a sort of check and challenge process with each of their borough-based plans. We're also working very closely with London region, where the responsibility for flu delivery actually sits, to look at what we can learn from other places and to do some of that connection with our practices at all. So a very active process that's going on now. Tomorrow we're having a discussion at the executive not only on flu vaccination but also on childhood immunisations, which have fallen somewhat across London in the middle of during the COVID pandemic. So some of these things are being managed.
Thanks, Angela. And I know, I think we're, as I understand it anyway, we're waiting for some further guidance in terms of any additional cohorts.
Yes.
And I guess it's worth just flagging, partly because the key question in my head, of course, is will we have enough? From what I'm hearing, you say there is definitely planning for an increased uptake. So I'm assuming the answer to that's yes, but it would be great just to reflect on those additional cohorts if we know anything about them.
So so we haven't had any formal notification about the additional cohorts. We are thinking about the extension of the older age groups down to post 55, but we're waiting to hear about that. And I think part of the reason that we haven't heard about that is that when we're told about an additional cohort, at that point, additional stocks of vaccine will have to be made available, because we certainly don't have sufficient stocks for an extended cohort. But we are aware that that's on the cards as well.
And particularly, I'm assuming those groups also, for example, who are shielded, who wouldn't normally necessarily be in, although I'm assuming the majority of people who are shielded would normally be in our at-risk groups, right?
That's absolutely right. Almost there would be very few shielded patients who wouldn't be in the category that requires flu immunisation. And of course, we do have housebound services for those patients that cannot leave the house. So district nurses, for example, will go and visit those patients. But we need to be particularly careful about the shielded patients having their flu vaccinations.
And their carers, of course.
And their carers,
yes.
Right.
No, absolutely. So sorry to put you on the spot. It's something that I feel is sort of an active conversation and helpful to update people on. So thank you, because I know you're very close to that work. Can I then hand over to Christina, because we're going to take some questions that have come in now. And Christina, if I can ask you to perhaps read out the questions, and then I will turn to members of the governing body to respond. I think you're on mute, Christina, so it's been great so far.
Most people prefer it that way. Yes, so thank you. We've had a couple of questions come through. I've published all of the questions that we have received. There were a couple related to the regional changes to London Health Services plans, which I think have already been picked up when Andrew and Sarah were speaking, and I flagged that to the person who raised the questions time, so we'll just cover the others. The first question is about engagement. Do you have patients from all boroughs on the new engagement group, and will this be the assurance engagement group going forward?
Thanks. So shall I pick that up, John T?
Yes, do please, Joy. That would be great. Yes, thank you.
Yes, I think many of you will be aware that during January and February we went out to discuss and engage with the public in all of South East London about our approach to engagement going forward in South East London. And we had lots of feedback from that, and it was around all the different methods of engaging, but also around the Engagement Assurance Committee, about how we could assure the governing body that we were fulfilling our duties around engagement. Clearly things came to a bit of a pause, but we've started that work off again, and we've been back to everyone that was involved previously, and we've now set up task and finish groups. I mentioned earlier on 4 topics, but one of them is specifically on the Engagement Assurance Committee. And for each of the task and finish groups, we've got members from across the boroughs talking specifically about the topic for that task and finish group. For this one, we've had one meeting so far, which was last week, when we looked at our duties and the purpose of the committee. We've not yet got down to the membership, but the task and finish groups will last for maybe 3-4 meetings. They're only going to be short-lived, by which the end product will be terms of reference for a committee that reports directly to the governing body and to provide assurance around engagement. We've had lots of contributions already. If the member of public that sent in this question would like to email me directly, would like to contribute views, I'd be very happy to take those. My email address is joy.ellery@nhs.net. That's ELLERY. But we are, as I said, working through this, and I would hope within 4 weeks at the maximum we would come up with the terms of reference, which I would certainly expect will contain patient representatives from across South East London.
Thanks, Joy. Really full answer, and appreciate that. Thank you. Christina, next question.
The next question I'm going to do in 2 parts, if that's okay. So the first part, and I'll just read it out. Potentially worrying details are emerging for Italy and elsewhere that COVID affects not just the respiratory system, and actually can affect other organs in the body, including the brain, even if they've just had mild symptoms. Given this information, should further individuals be shielding, especially if they are, for example, cancer survivors, etc., or if for other reasons, such as if they only have 1 kidney or if they have multiple comorbidities?
Thanks, Christina. So I will do my best to answer that, partly because it was an item on the Clinical Advisory Group for South East London's agenda. So I chair that group. It's a group of medical directors and clinicians from across the system, both commissioners and providers. And one of the things that is absolutely emerging is a greater understanding of the effect the virus has on the body, and particularly long-term effects. Some of those are directly related to the virus. Some of them are related to people spending extended periods, for example, on intensive care, which has associated with it some long-term impact as well, both on people's physical health, but also importantly on their mental health as well. There's some work going on at London level at the moment to try to bring together the evidence that exists and to develop a set of standards about how we would best support those people who have had the virus and who have ongoing symptoms and effects and impact in relation to that. I have taken an action following that meeting to convene a group in South East London. It's going to be important that we bring together people from a range of different specialties, including around rehabilitation and primary care, as well as mental health colleagues and intensive care specialists and our respiratory colleagues, because of course the principal impact is and continues to be on the respiratory system. So we will be convening a group to look at how we develop a pathway of support and care for those people following infection with COVID, that very much reflects, I think, some of the impact that the questioner is asking about. Now, I suppose what I would want to do, though, is just slightly separate or differentiate between the impact the virus has and the risk of acquiring the virus. They're not quite the same thing, and I think, therefore, the learning that we're now doing on the impact the virus has doesn't necessarily change our understanding of those people who are at risk of getting the virus. However, that also continues to be something that is reflected upon, and people obviously will have heard in Kevin's interview and public health data that's coming out. Our understanding about those at-risk groups continues to improve, and of course the work that we do to help to protect people, identify people proactively and support them, whether in shielded or high-risk groups, is going to be critical. And Angela's just talked about, for example, flu vaccinations, which will be a part of that programme going forward. So yes, we definitely are increasingly understanding the impact of the virus, and we need to think about how we provide the right support. That doesn't automatically mean that there's a difference in the groups of people at risk, but we are absolutely focusing on those groups and how we can best support them and keep them safe as part of our ongoing response to the pandemic. I hope that's helpful.
Thanks so much, Jonty. The second part of the question is slightly different. How are members of the public supposed to know which public body is ultimately responsible for the various aspects of healthcare within our 6-borough locality, i.e. South East London? And is there an easy way for people to understand this?
Thanks. It's probably most helpful to bring Andrew Bland in response to that question. Andrew.
Thanks, Chair. So I don't want to treat the question too literally, but the literal answer is, if we're referring to the commissioning of health services for South East Londoners to our registered population, the body ultimately responsible is this governing body, so the CCG. If perhaps be a slightly more helpful than that, then I wonder if Christina and I might commit to working with our comms team to take the point that perhaps a dashboard of which services are under delegated responsibility to borough-based boards would be helpful, bearing in mind that's still in the commissioning space, and just to call them out as by and large what we've termed the out-of-hospital system. So it is primary, community, mental and physical health commissioning, continuing healthcare, and those services under continuing healthcare and prescribing. But we can attempt to make that clear. We had attempted to do so through our sort of what was prospectus and now introduction to the CCG, and the dashboard sounds like a good idea to me. Just to be complete on the question, however, within our partners, if you are a hospital or a general practice or some other service provider, you're usually subject to an NHS contract, and so the boards of those organisations are accountable for the services required under those contracts. So for a GP, that would be the General Medical Services contract, or for most other NHS providers, it is the NHS standard contract as applied to their area of care. I think the overall answer is the buck stops with us for the commissioning of services as a CCG.
Thank you, Andrew. That's helpful, and I think an offer there to do some work outside the meeting, which we will capture as an action in relation to this in the minutes. Thank you very much. So, Christina, further questions?
Yes, penultimate question. Related to testing, are there any plans to blanket test those who were deemed extremely vulnerable or advised to shield and have been doing so? It appears that the shielding recommendation may be coming to an end soon, and can they reintegrate with society without tests to indicate if they or others that they might be exposed to have been in contact with the virus? If there isn't a plan, could we articulate that? And linked to that, do we know, and this may be one that we need to come back to, how many residents within South East London were deemed extremely vulnerable or advised to shield?
Thanks. So probably, I think if I could bring Angela in, I don't necessarily want to put you on the spot in terms of numbers, Angela, because being expected to sort of pluck that out of your head is challenging, so we may need to come back to that. But did you want to respond to the rest of the question?
Yes, thank you. And yes, I'm afraid I don't know the actual number, but it will be in the thousands who are shielding in South East London. On plans to blanket test those who are extremely vulnerable, there are no centralised plans to do that at the moment. We have talked about certain vulnerable groups where there's a clear evidence base that I think suggests we should be testing them. So we mentioned earlier those residents in care homes who are exposed to people coming in and out of their living environment in the form of carers. So there's a very clear reason that we would want to test those people looking after them and their and the residents themselves. However, we don't have any plans to test those who are shielded, and of course that isn't the main issue of what we're trying to do in addressing the COVID pandemic. What we want to do is to prevent those people becoming infected, and this is where the use of masks, social distancing, being careful about contact with others actually comes into its fore, because that is what will protect people who are shielded from getting infection. I think the problem is that once people are infected themselves, there's very little that can be done about it except to treat those patients symptomatically. We have talked several times, I think, through this meeting about the fact that we're still learning about this disease and learning its full impacts and learning how to manage it. And at the moment, there's no single treatment. So identifying people very early on may not actually make any difference to them. But I think it is important where perhaps carers and healthcare staff are coming into contact with people, and I think there's much more of a sort of case for blanket testing of that group of people rather than those who are shielded themselves. But we will come back on some of those issues and also the numbers that are shielding, or approximate number that are shielding.
Thanks, Angela. So it's really helpful just to have that sort of immediate answer, but absolutely we will pick up on any further detail as part of the minutes, so that we ensure all of those questions have a full answer. Any further questions, Christina?
Just one last one, and this is about whether the local authority public health teams have access to COVID data at a postcode level. And linked to that, have we liaised with public health colleagues in Leicester to draw an experience of managing a local lockdown?
So I just wanted, is Nada still on the line? Because I'd wondered whether, yes, Nada, are you happy to respond to that? And I may then go to Angela afterwards as well, just for her reflections in terms of Leicester, if she has any. Yeah.
Yes, thank you. The first part, yes, we do have postcode data on patients, on cases, which we regularly receive, which is important as noted, because that's the way that we can monitor the situation, have a health surveillance information, which then, and we monitor trends, we monitor geographical spread, we monitor the situation on the ground, which can give us an early warning of any potential outbreak. And yes, in terms of Leicester, equally, we have been through Association of Directors of Public Health, a lot of learning has been shared. The Director of Public Health from Leicester has been in one of our joint courses where he did provide a lot of information about what was happening, what they did, what were the lessons to be learned, and so on. So yes, the answer is yes, we know quite a lot about it.
Thanks, and again, reiterating the importance of data and how we understand the challenges. Angela, did you have any further reflections? Because you're very important.
No, I just wanted to say that the actual levels of positive tests in Leicester is what has led to the lockdown there. So at the peak, there were 140 per 100,000 positive tests in Leicester. It wasn't about increased numbers of deaths, it wasn't about increased admissions to hospital, but about the number of tests. In South East London, we in each of the boroughs, there are only a handful of positive tests per per 100,000 each day. So we're not talking about very, very many. I think one of the other things that I would just like to reassure the governing body about is that the Gold team meet every day and review a set of early indicator warnings, which includes numbers of positive tests, numbers of admissions with COVID-19 to hospital by site, a number of people in critical care with COVID-19. So we're very carefully monitoring our levels so that if we do see a rise, we'll be able to spot it early on. And we're working very closely with our public health colleagues on that as well.
Thanks, Angela. Again, I'm going to put you on the spot only because I know that you are quite close to this, so you may be able to answer for me. But I had also read a paper that indicated that contact with 111 is quite a helpful sort of data in terms of early indicators. Is that something that we have access to as well?
Yes, it's one of our early indicators. Sorry, it was the one I didn't mention, but it is one that we look at as well every day.
No, that's great. Thank you. Because I know, again, being able to identify these things early is going to be critical to any future spikes. Good. Christina, does that cover the questions that have come in?
Yes, there were a couple of sort of responses to our answers. One just about the fact that with the sort of variation in responsibility across the system, which Andrew mentioned, there's a comment that does that indicate a fragmentation of the system.
Okay. Yes. Okay. And any other comments? I'll happily wrap up with that. Yeah.
And then the last one was the testing question was to determine a baseline. Is there any reason to assume that vulnerable or shielding people had not already been exposed to the virus or be asymptomatic?
So let's pick those up in terms of just providing a kind of fuller response and to any other questions that have come in. I know some of this has been picked up during the meeting itself, but we'll make sure that we wrap up with any of those additional questions that have come in as part of the minutes, and they will be published, of course, so that people will be able to see those. I guess just to be very clear in terms of fragmentation, one of the things that I have observed over the last few months has been just how closely teams are working together across different organisations, as I say, across sort of between commissioners and providers, between community and acute and general practice. So actually what I've observed is much closer collaboration and working, and I think that's provided some really important learning and allowed us actually, I hope, to accelerate some of the work that we're doing collaboratively towards integrated care. Undoubtedly, the particular pressures that emerge and the approaches that we have within individual organisations and institutions do inevitably drive particular responses, but I'm really impressed by the way in which across South East London people have stepped outside of that and really looked to provide support across the health and care setting in a fantastic way. So that may not have picked up the detail, but I hope responds a little bit to that. So I don't know whether you wanted to add anything finally, Christina. Did you want to?
I think I definitely would certainly echo that, and I think COVID has been an excellent example of close working. I guess the other thing to say as well in terms of the responsibilities across us as commissioners, we paid quite careful attention as we were going through the merger programme to look at where responsibility best sits and where it makes sense to align service decisions with kind of local communities. So it wasn't about fragmentation, and clearly we still work as a single CCG, but as a commissioning organisation we're quite careful to look at where we felt we could take the best and most effective decisions.
Thank you, and thank you for having done such good work helping us to manage the process of the technology and the meeting and orchestrate it so well. Thank you very much indeed. I think that brings us to the end of the meeting. Can I just check with members of the governing body whether there is any other business? I'm not aware of having been notified of any, but can I just double check? Okay. in that case, I guess I just wanted to finish by reiterating my thanks, not just to the incredible work that's been going on by members of the team within the CCG, but also the providers of care services across South East London, and carers themselves, who we know play such a vital role in supporting our local population and local residents. It really continues to be a phenomenal, bless you, Christina, a phenomenal response. And I think, you know, Christina's already alluded to the learning that has come out of this. I think one of the things is we're undoubtedly moving now from, I guess, a sprint into a bit of a marathon. And that means we have to pay really strong attention to the well-being of our staff in those provider organisations. I know it's something that has been picked up very much by colleagues in the CCG. It's incredibly important. People are inevitably tired. They've been working incredibly hard, and we've already started talking, as you've heard, about winter and the potential impact that there will be there. So I very much hope that people do manage to get a break over the summer months. I guess it was just to highlight both the incredible good work that has been happening, but also the care and attention we need to continue to pay to NHS staff and other carers as we go forward over the coming months. So on that note, with a sort of huge sense of gratitude, and thank you to those people who have joined the conversation this afternoon, I'm going to draw a close to this meeting. Thank you very much.
Thank you.